Oh,
Hello. Good evening, everybody.
good. Yes.
Good evening, everybody. Respected President Sam, Dr. Avinash Bhosle, sir, esteemed office bearer Sam, today's invited chairperson, Dr. Kalpana Kelkar, madam, a retired professor and head from D.Y. Patil Medical College, Pune, then Dr. Madhuri Kundi, madam, editor-in-chief, IJA from ISA National, then today's esteemed faculties, Dr. Radha Savdekar, Dr. Ashwin Sonkamre, Dr. Shweta Sargavkar, Dr. Jayashree Rani, Dr. Farjin Qureshi, and Dr. Poonam Godti. Past office bearer of SAP, immediate past president Dr. Anita Neterman, all GC National, SAM's advisory, GC member, president and secretary of various city branches and SAM's member. I welcome you all in the SAM's curriculum How I Did It session. Today we have first time applied for MMC credit hours from our SAM's ACRI number, but the certificate is yet to come, but it is going to become. So those who want MMC credit hour, they can register by payment gateway once I posted. So we will start with the blessings of Ma Saraswati.
शीतल तुझा चेहरा दिसत नाही.
Hi.
शुद्धतेचे चांदणे अन पुन्हा पसरो मनावर शुद्धतेचे चांदणे माणसाने माणसाशी माणसा समवागणे ही जाऊची प्रार्थना.
Now I request our president Dr. Avinash Bhosle sir for his presidential address.
Good evening, everyone. And I welcome to today's SAM's academic webinar, How I Did It. I am glad to share you that just we have received our MMC accreditation letter from MMC, and this team is MMC accredited. As anesthesiologists, we train for the 95% of cases that follow the book. But it's the 5% that don't. And the ones that test our judgment, our calm, and our ability to improvise, and that make us better clinician. Every anesthesiologist may come across these cases that test skill, presence of mind, and clinical judgment. When protocols end, thinking begins. Today, 6 of our SAMS colleagues have volunteered to share those 5% such challenging cases, how they approached it, what worked, what didn't, and what they had to do. Differently. No textbooks they hear, just honest stories from the OT table that will help us all to become safer, sharper clinician. Today's format is simple. Each presenter will get 7 minutes to tell us how they did it, followed by 3 minutes of discussion by chairperson. There should not be any criticism. It's about collective learning. So one, how I did it may save your next patient, because the best experience, the best knowledge comes from the experience. Let's join and listen to this webinar. Thank you very much. Over to Sheetal.
Thank you, sir. So taking this opportunity, I would like to request all the delegates to kindly register for our Maharashtra State Conference, that is SAMSCON 2026, which is going to be held on 2nd, 3rd and 4th October 2026 at Pachkani, and it is organized by Organization of Anesthesiologists, Satara. So to begin, now I request Dr. Anita Nethe Madam kindly introduce our first chairperson, Dr. Kalpana Kelkar. Ma'am. Hello Nethe ma'am.
Hello. Okay, I'm sorry.
हॅलो सगळ्यांना आवाज येते का? इज इट व्हॉइस इज प्रॉपर?
Audible.
Yes,
The
yes,
volume is
audible.
good.
आवाज कमी आहे
There is
थोडा
message
कमी आहे
that
आवाज.
sound is just low or it is not audible.
नाही, it was low for the prayer, but now it's okay, I think.
It's good
Okay,
now.
okay. Okay, thank you. Thank you.
Thank
Just please continue.
Thank you, Dr. Sheetal. It gives me immense pleasure to introduce my teacher, though I didn't actually was her student, but I have worked with Dr. Kalpana Kelkar Madam at BJ Medical College, and gives me immense pleasure to introduce Madam. At present, Madam is working as a retired professor and HOD of Critical Care Medicine at DY PMC Pune, and she was an ex-HOD of Emergency Medicine, KM Hospital Pune, and head of the department of BJ Medical Pune, retired professor and head of BJ Medical Pune. And Madam has trained n number of students during her whole career as a teacher, and her expertise in various like today's topic. So in various things which are actually not given in the book, but they are required for the clinician and private practitioner at the ground level. So her skill and expertise and empathy is extremely laudable, and we look forward to Madam's various comments on these our today's speakers' presentations. So she has multiple publications in index journals and research projects, and main thing is she has too many students which are spread all over India, and we just love you, Madam. Thank you.
Thank you.
Welcome ma'am. Now it's my honor to introduce our next chairperson, Dr. Madhuri Kurdi Madam. She doesn't need any introduction. Presently, she is an professor at Department of Anesthesiology, Karnataka Medical College and Research Institute, Hubballi. Then she is a postgraduate teacher since 28 years and PG examiner. At present, she is editor-in-chief, Indian Journal of Anesthesia from 2025 to 28 and associate editor of Journal of Association of Clinical Pharmacology, Anesthesiology and Clinical Pharmacology. She is an associate editor of Practical Evidence in Anesthesia, and she is also associate editor Vapor, the official newsletter of ISA National Advanced Course of Medical Education. Since she is a winner of ISA IJ Best Peer Review Award for IJ 2016 and 17. Then she is a winner of ISA National Proficiency Award 2021, ISA President Appreciation National Award in 23, ISA Karnataka Eminent Anesthesia Teacher Award, and ISA Bhopal National Award for Academic Excellence in 2024. So welcome, ma'am.
Welcome, ma'am.
Thank you so much.
Now I request Dr. Shilpa Tivaskar to introduce first speaker, Dr. Radha Saud.
It gives me immense pleasure to introduce Dr. Radha Saudekar Madam. Madam is Director, Suyash Trauma Center at Amravati. Madam is Associate Professor at GMCH Amravati Hospital, AHA Certified Instructor and BLS and ACLS Instructor. Madam has major achievements to her credit. She was at IMA Amravati Secretary 2025-26, President of ASA 2024-25, then co-chairman and CPR and First Aid Committee of IMA MS at 2025-26, faculty at WASCON 2017, National Workshop on Trismus in 2019, and Massicon in 2020, Amravati, and Amravati Anesthetic Summit at 2025. Chaired sessions at UACON UACon Nagpur 23 and Biennial CME Karad 2024. Madam has participated as speaker in many state and national conferences. Her achievements: gold medal for MD anesthesia in the university, recipient of President Appreciation Award at Karad 2024, winner of Badminton Championship IMA MS State 2016, winner of Roto Sports at Jalgaon in 2012, and passed the Gita Pathak exam with 100% marks, and lot of prizes and accolades. And we remember you, madam, where you had taken all the anesthesiologists of Amravati together to increase the remuneration which the anesthesiologists were getting. So salute to you and welcome to you.
Thank you. Thank
Over
you
to
very much.
Dr. Sheetal. Yeah.
Thank you, Dr. Shilpa. Now I request Dr. Radha ma'am to kindly proceed for her presentation.
Madam, you are able to see?
Yes. तो खालचा ऑरेंज एरो परत प्रेस करा.
Yes, yes. Ha.
Yes, ma'am.
Very good evening to all the respected SAM's chairpersons, President Sir, Sheetal Madam, Honorable Secretary Shilpa Tivaskar Madam, and the chairpersons for today's session. Thank you very much for giving this opportunity to GC Amravati to represent and share my experience with one case where literally many things were masked, but it was, as an anesthesiologist, you know, we always have the a view of finding out something like Sherlock Holmes. So I was really saved in that case, and I would really be happy to share with you my experience. So it was a simple looking case, a 30-year-old male patient for a redo ortho surgery. He was a painter by profession, had a fall while on work. It was operated case of left proximal femoral nail, fracture neck femur 10 months back under spinal anesthesia. The procedure and hospital stay that time was uneventful. He was not on any medications. The patient just gave history of fever, one episode 3 days back before his fall. No otherwise comorbidities, no hospital admission apart from the previous surgery, and tobacco chewer since 10 years. So otherwise looking as ASA grade 1. And once the patient gets admitted in any ortho hospital, the tendency of a surgeon is that once the pre-op comes, if all the reports are normal, they immediately post this the case for the next day. So this was the X-ray, and he just didn't have again the fracture, but even there was an implant failure. The nail had also fractured. So the patient was posted for nail removal and proximal femoral nail to be done in the same sitting. So approximate time as per the surgeon was 2 to 2.5 hours. On PAC, I found out that the patient is young adult, otherwise anxious looking, fit, around 55 kgs, afebrile, ASA grade 1, no anticipated difficult airway. The only alarming thing which I found on my PAC round was pulse rate was 146 and the blood pressure was 160 by 100. So quite a bit high for his age. The first PAC report, the pre-op report which had come, hemoglobin was 8.9 grams. WBC counts were on the lower side, 1900, and platelets were 93,000. Because he was having tachycardia, a ECG was asked for, and the ECG also confirmed that the heart rate was indeed around 148 to 146 per minute. And that is the reason why a physician opinion was advised. Physician opined that he should be started on Nicardia, 10 milligram retard, twice a day. And because he's anxious, maybe tobacco chewer and nicotine induced, he might be having tachycardia. So alprazolam was advised to him, 5 milligram HS. And because he gave history of fever, and antibiotic was also started. And the physician opined that if the repeat CBC after 24 hours comes normal, you can take the patient for the surgery. So after 24 hours, again the patient was reviewed. Heart rate was still 145. BP was still on the higher side, not as the first visit. So it was observed that the patient was having tremors, in fact, when he was having water. So it was just by chance that I am entering the room and the patient is drinking water. So somehow I was not comfortable with the patient. So I advised, the patient needs further investigation. Kindly send his thyroid profile the next day. And this was the thyroid profile what had come. His TSH was actually 0.01 with T3 of 471 and T4 of more than 24. So indeed, it revealed that the patient was having thyrotoxicosis, where he had not given any previous history, no medications, nothing. So then the patient was started on tablet neomarcazole 10 milligram BD and tablet propranolol 40 milligram once daily. The USG was advised and the report was showing scattered in both the lower lobe, suggestive of likely multinodular goiter. The coagulation profile was normal. LFT and X-ray were also normal. After 2 days after starting of the anti-thyroid drugs, his CBC was repeated. Hemoglobin was 10.9, WBC count was 2,400 and platelets had come up 1,10,000. He was nicely beta blocked. Heart rate from 148 had come to 104, but tremors had persisted. This was the ECG, which was showing 100 to 104 per minute heart rate. Now, the thing was that this patient had basically, the surgeon said ki surgery to karni padegi, madam, because it is a weight bearing bone. He was a young patient. And even he was not ready to get postponed to become euthyroid, normalize the thyroid hormones. I tried to convince him, but he said ki no, we are ready to go in for the surgery because 10 months back हमारी surgery हुई है and हमको कुछ नहीं हुआ, तो अभी क्या problem है? So the anticipated otherwise issues were that apart from redo surgery, orthopedic procedure, blood loss was also there. And you never know if an implant has to be removed and put in again. So time constraints, it can exceed. So you have to be flexible regarding the anesthesia timing also. So the patient was in thyrotoxicosis, weight-bearing limb. The sole earner of the family refused postponement of surgery. To achieve euthyroid in this patient would have typically taken at least 2 to 3 months. Putting the patient in Thomas splint for that much duration again increased the risk of bed sores and infections. So taking up the surgery also carried the risk of severe arrhythmias, especially atrial fibrillation and heart failure. So perioperative stress itself may exacerbate the underlying condition. So viewing all the pros and cons for the surgery and anesthesia, it was decided that the surgery needs to be done. So first and foremost, we identified the goals, what we want to achieve. We want to have a good analgesia, a T10 sensory block. The drug used for regional anesthesia must not result in any cardiovascular instability because already the patient is in thyrotoxicosis. Replace blood with a packed cell volume, of course, and adequate measures should be taken if need arises to prolong anesthesia. So all these considerations taking into mind, we proceeded for the procedure. Preoperatively, on the day of surgery, the patient was advised to take his anti-thyroid drugs, neomarcazole and propranolol, with sips of water in the morning. Then he was given antibiotic piperacillin tazobactam 4.5 grams. Hydrocortisone 100 milligrams. Steroid was given because it is known that steroid definitely reduces the conversion from T4 to T3. And sedation was given because anxiety was still there. And injection tranexamic acid was also given preoperatively. Considering all the pros and cons, regional anesthesia was only shortlisted, of course. And spinal anesthesia I wished to avoid because whatever drug you use in a subarachnoid block, maybe you use a 0.5% bupivacaine or 0.75% ropivacaine, there has to be some or the other amount of hypotension, at least 15 to 20%. So I thought it is better I use a hemodynamically stable anesthesia, which will hardly result in any changes on the cardiovascular status. So an epidural catheter was inserted at the level of L2, L3. The catheter was fixed at 9 centimeters. Drug given. Now here I really thought of all the drugs possible and whatever will happen if I give this, if I give that. Then I ultimately thought it is a limb surgery. It is not an abdominal surgery. There is no issue of, pushing and pulling the abdominal contents. So what the surgeon wants is a calm and quiet patient. What the patient demands is good analgesia and a little bit of anxiolysis. So I decided I will be giving 0.2% ropivacaine because the strength is so low, it will hardly cause any changes in the hemodynamic status, and that too epidurally given, it won't change much the blood pressure because I cannot again give mephenterine or ephedrine to even short acting to increase the blood pressure. So I basically wanted a very hemodynamically stable patient and the drug which won't cause any issues on his cardiovascular status. So at the time of incision, approximately 25 minutes after the first I gave, the first dose was 0.2% ropivacaine 6 ml. And then the patient was turned into lateral position. And approximately after 25 minutes after the first epidural dose, it was that the time of incision was decided, and that time 4 ml of same 0.2% ropivacaine was given. Then after 45 minutes after the second dose, again 4 ml of the same drug was repeated. The last top-up was given at the time of closure. That means 45 minutes after the third dose. It was 8 ml of 0.2% ropivacaine with 25 micrograms of fentanyl. So this was the timeline. First dose 6 ml of 0.2%. Second top-up 4 ml. Third top-up 4 ml. Fourth, that was the post-op analgesia. It was 4 ml again because it was diluted to it. Very less strength of ropivacaine I had used in this case. So the total of 18 ml of 0.2% ropivacaine was given over a period of approximately 2 hours 30 minutes to 2 hours 45 minutes. Intraoperatively, I gave 1 liter of crystalloid, 1 ringer lactate and 1 dextrose normal saline. Blood loss was around 350 ml. No transfusion was given. The patient remained absolutely rock stable throughout the procedure. The heart rate was maintained between 100 to 110 per minute. Blood pressure was maintained from 120/80 to 140/90. No major fluctuations while using this drug. IV hydrocortisone, as I told you, 100 milligram OD was continued 3 days post-operatively also. So then after 48 hours, the epidural catheter was removed. The patient was discharged on 4th day post-op and advised to take his anti-thyroid drugs and follow up with the physician. Thank you. So this was actually as per the books, as per everything, we say that thyrotoxicosis patient should be turned euthyroid, but to make him a euthyroid, it at least takes 10 to 12 months. Until that time, no elective procedure should be undertaken. It is as per the standards what we follow. But in this case, I could not postpone the case. I could not tell him that no, you come after 10 months, you come after 3 months, we will repeat your thyroid profile and then we will do. We had to take him. Accordingly, consent was taken, everything was done. And that's how this is the first thyrotoxic case actually in my entire life which I had done. So
Thank
this
you,
is the
Dr.
way.
Radha ma'am.
Thank you.
Over to chairperson, Dr. Kekar ma'am. Hello.
Hello. Hearty
Hmm.
congratulations for the expert management which was done in this case. But I would like to congratulate the anesthesiologist more for her diagnosing capacity and proving the point that the anesthesiologist is a perioperative physician, because the physician
Yes,
had seen the patient and the physician failed to do the thyroid function test, which cannot be understood. Because when the
yes,
pulsation was
exactly.
what is
Exactly, because it was just the heart rate, increase in heart rate was just turned down as the patient is anxious and the
no, but
patient
then
is having sleepless nights. That's
no,
what.
no, but then and even the other parameters, actually, I suspect, did the patient have any history of any fever in the recent past?
He had, madam, fever 3 days
Because
back
you
before
see,
the fall.
his blood chemistry is suggestive of some dengue infection or something, because the platelets 93,000, the WBC only 1900,
1900. First was
Yeah.
1900.
and hemoglobin 8.9. All these
Hmm.
were actually, when I started imagining, because even your title was very good, I was
Hmm.
wondering what must be the mask. And then I was wondering whether this patient had some blood dyscrasia, even amounting to some blood cancer or things like that.
Even
See,
initially,
because
madam, actually, I
yes,
thought the same. But when
yes,
it turned out to be that TSH is only 0.1%,
yeah,
then
that
it
was
fit
pretty
into
clear.
that.
Yes.
That's what.
But then in this case, I would have appreciated if the case could have been postponed for, say, 1 week or so, for some better control of the thyroid. You were lucky that the patient did not have a thyroid storm. Uh, and secondly, a combined spinal epidural could have been a better choice. I would have preferred it, because
Actually, for that, I thought, madam, but now my experience, whatever drug you use in spinal, it does cause hypotension. Some amount or the other from the baseline, it definitely decreases. And then I was worried more about the arrhythmias factor. So that's how I felt ki epidural would be, and that's what I said, na, because it was a lower limb
yes,
surgery, not
yes,
much muscle relaxation lag
that's
raha
true,
hai,
but then we can give a lower spinal for a, because there is a complete sensory blockade. And if he is a 55-year-old patient, some muscular relaxation also is
No,
required,
he
because
was
I have noticed,
30. Yes, okay, okay. I would definitely, but
because
this
the
was
case
like,
was done uneventfully and the surgeon was happy with it, so the epidural worked well. But and the first dose also could have included fentanyl for a denser dose.
yes, okay,
Uh,
okay. That which I gave like
yeah,
post-op
you
analgesia.
gave only for post-operative analgesia.
Yes,
We
yes,
would
yes.
like to have the opinion of the house also, if there are any comments from anybody. Yes.
Comments are there, but Dr. Sheetal, do you want to ask the second chairperson?
Hello, Dr. Madhuri, ma'am.
Yeah,
Hello.
yeah. Dr. Radha,
Yes, ma'am.
here you are actually, this is a case which has undergone surgery 2 times. So the
Yes, 10 months back.
first time it was hidden hyperthyroidism, which was post-operatively was detected with thyrotoxicosis, isn't it?
Yes,
And
yes.
the second time you very well knew that the patient was hyperthyroid.
No, excuse
So
me.
No, madam.
Was the first exposure followed by thyrotoxicosis, Tom?
No.
I missed it. No.
He was operated somewhere else 10 months back
Huh.
for the neck femur, and he didn't give any positive history.
okay.
Absolutely uneventful hospital stay during that time.
So is it
That's what.
possible that the thyroid disease itself presented after the surgery? That is a
Maybe.
possibility. Yeah, we
Could
don't
be,
know.
yeah,
Yeah.
possible. Maybe he had or maybe he didn't have the
Yeah.
first time. Yeah, and Dr. Radha, actually in thyrotoxicosis, the local anesthetic dose, how did you decide? Like your patient was hyperthyroid, no?
Yes.
When you gave. So the dose of local anesthetic, how did you decide? Like,
Mm,
you
basically, I wanted a sensory block.
actually here it should be based on the lean body weight,
Yes. He was a
especially in
55.
hyperthyroidism. And
He
one
was
more
a
thing
50.
you have to keep in mind is, of course, you should not use adrenaline and such kind of adjuvants when you're administering the local anesthetic. ठीक है?
I have not
No,
used.
you
I
have
have
not
not used.
used. I'm just discussing that we should not
Yes.
be using because they can trigger tachycardia, hypertension, and
Hmm.
arrhythmias, isn't it?
Yes.
And which local anesthetic you used? Ropivacaine.
Okay.
Yeah,
Any
ropivacaine,
specific reason why you
0.2%.
chose? Any specific reason why you chose ropivacaine? Like,
Madam, the strength he was the lowest of ropivacaine,
okay,
0.2%.
okay,
So I used it undiluted because it comes in a 20 ml ampule. It's very
ठीक है.
easy, no need of dilution and nothing. That's what.
Okay, definitely. Well managed case.
Thank you.
Hello,
Thank you,
now
madam.
coming to the next case. So next speaker, is
We'll
Dr.
take the
Ashwin.
questions later, right, Dr. Sheetal?
Later, yes, yes. So next case is next speaker is Dr. Ashwin Sonkampe. Now I request Dr. Sachin Tandurkar sir to kindly introduce our next speaker.
Thank you, madam. It's pleasure to introduce our GC Ashwin Sonkamble sir. He did a multifaceted person, having completing MD NCR. He did LLB, LLM also with a diploma in acupuncture. He's presently at associate professor at Grant Government Medical College and Surgery Group of Hospitals, Mumbai. And he's a life member of ISA, IMA, and ISC. He's also vice president of NGO PEI Sonkamble Trust and a mentor for MEDA conducted by IIT Bombay. He is also felicitated as a Corona warrior by the Honorable Governor of Maharashtra during September 2020. Felicitated by Honorable Chief Minister of Maharashtra, providing healthcare services in rural Maharashtra 2016, and National Award for Concept of Novel Surgical Device in Medical Hackathon during 2022 by IIT Mumbai. Awarded Best Associate Professor at Grand Medical College in 2016 and nominated for SARC Award in 2018 for providing healthcare services in rural Maharashtra. Sir got numerous awards also for script writing and direction of skits. He got second prize at State Conference Solapur 2019, third prize at State Conference Nagpur 2021, and first prize at Mumbai 2018, and multiple Indian journal publications. Sir, I have. Over to sir.
Thank you, Dr. Sachin. Now I request Dr. Ashwin Sonkampe sir kindly proceed for his presentation.
Yeah, thank you. Thank you, Sachin, for the kind words.
Thank you, sir.
Is it visible, the screen?
Yes,
Yes,
yes.
Yeah.
Yes.
Yeah, I am going to discuss a case of stuck LED stent assembly in a case of reduced CABG and the anesthetic considerations of this case. So we had a case of a stuck balloon which was attempted in the cath lab, and with the background that entrapment of coronary angioplasty devices is a rare but potentially catastrophic complication, and failure of percutaneous retrieval necessitates emergency surgical intervention. So redo CABG in the presence of retained intracoronary hardware poses unique anesthetic and surgical challenges both. We had a male of 74 years who was a known case of hypertension and coronary artery disease, and he had undergone CABG in 2012. Presented with progressive external dyspnea of class 2 NYHA for the last 6 months. He was scheduled for percutaneous intervention after evaluation for recurrent coronary artery disease. So coronary angiography demonstrated progression of native vessel disease despite previous CABG. PCI to LAD was attempted, and during the deployment, the balloon stent assembly became entrapped within the LAD. So percutaneous retrieval attempts were unsuccessful. The patient was taken up for emergency redo CABG and surgical retrieval of retained device. So patient was hypertensive since last 20 years, undergone CABG with the following grafts, following 3 grafts to LAD, OM1 and PDA. He was a former smoker and tobacco chewer. There was no history of diabetes or chronic lung disease. And he was on aspirin, clopidogrel, and then atorvastatin, metoprolol, and he had received heparin 7,000 units during the procedure for angioplasty in the cath lab. So he was conscious oriented, hemodynamically not very stable actually. Heart rate was 110 and blood pressure was 80/60 on injection NORAD at 5 ml per hour with a concentration of 4 milligram in 50 cc. The saturation was 99% on room air. So he was relatively unstable when he was taken to the OT. he has Malampati grade of 2, poor dentition, multiple missing teeth, adequate mouth opening and neck movements were okay. So this revealed a previous scar. Bilateral basal crepes were there, indicative of some amount of element of left ventricular failure. Heart sounds were normal, and you could see the sternotomy scar here. He had these were investigations were before the angioplasty, all which I am going to tell you. So hemoglobin was 13.5, creat was raised, and potassium was on the higher side, and INR was also deranged. We didn't do means APTT was not done in this case, and ABG showed the following picture with a PaO2 of 82 and PCO2 of 38. BICA was okay. ECG showed sinus rhythm, and there was T-wave inversion in inferior and lateral leads. Bilateral lower lobe haziness suggestive of pulmonary congestion. So this is the picture of the TEA. They had done in the cath lab. We didn't put it in the OT. He had a left ventricular ejection fraction of just 25%. This was pre-angioplasty. Dilated left ventricle with global hypokinesia, grade 1 diastolic dysfunction, mild mitral regurgitation, and LV systolic function. Sorry, this was a picture on echo, 2D echo, not TE. So these are some of the pictures of the angiography. Severe triple vessel coronary artery disease. LAD was blocked significantly, diagonal artery also. Chronic total occlusion of the RCA, total occlusion of the LCX, and patent SVG graft to PDA from the previous CABG. PCI complicated by retained balloon stent assembly within the LAD. So this is how the picture was when the sternotomy was done. There was oozing, quite a lot of oozing. Even sternotomy went on for almost half an hour because of the adhesions from the previous surgery. And this EF was 25% before the angioplasty. And the echo was not done after the incident happened. So it might have gone down also. Maybe it was 15 to 20% during the when the patient was taken into the OT. So it was a high risk hemodynamic instability during induction. And anticipated blood loss was there because of the redo procedure. A lot of adhesions there, and INR was deranged. So we expected this thing. Previous CABG had given mediastinal adhesions also. Mild renal dysfunction was there, and INR was also deranged. So we applied standard ASA monitoring, IGV, and left femoral artery lines were taken as usual. Induction was done with fentanyl. For the line, hello? Hello?
Please continue.
Actually, there was some disturbance, I think. Okay.
There is disturbance from.
Achha, yeah. Okay, sir. Fine. We usually give fentanyl and midazolam before taking up lines to get some amount of induction, sedation, and to reduce the anxiety also. So we used fentanyl, then midazolam, and etomidat was titrated. Total of 12 milligram of etomidat was given, and atracurium was used as a relaxant. Endotracheal intubation was done with using video laryngoscopy, and anesthesia was maintained with air oxygen, desflurane, and neuromuscular blockade. Cardiopulmonary bypass was instituted following systemic heparinization, but it took a long time to go on to the cardiopulmonary bypass because of the adhesions and the surgical difficulties. So with sternotomy was done with careful adhesiolysis. Retained LED balloon stent was successfully retrieved. The LED was taken an incision after going on the CPB, and the whole assembly was removed from the LED site and not from the femoral site. Redo coronary artery bypass grafting was done afterwards. There was severe hypotension during the induction, managed with vasopressors. Ventricular fibrillation during rewarming, successfully treated with two shocks, one of 15 joules and one of 20. And patient was successfully weaned off from cardiopulmonary bypass with inotropic supports in the form of NORAD, dobutamine, and adrenaline. So, 4 FFPs were given before we took the patient for the procedure, before the OT. Then 4 PRBCs. During the intraop period, we had to give 4 PRBCs. The blood loss was around 1500 ml. 6 FFP were given in the intraoperative period. RDPs were given 4 and 3 cryoprespirates. Shifted to the cardiac ICU under elective mechanical ventilation. The patient took 2 to 3 days to settle down, and he was extubated on the 3rd day, I think. Continued inotropic support and invasive hemodynamic monitoring in the ICUs also. Post-operative management focused on bleeding, ventricular function, and end organ perfusion. So this is the wire, guide wire. This one, yeah. See, you can see the broken this thing. The distal part was shown in the first slide. So these are some of the learning points. Anesthesia for emergency redo surgery is critical. You have to manage the LV dysfunction, then hemodynamic instability during induction, especially transfusions and adequate amount of blood products. Then cardiopulmonary bypass in a high risk. Then successful separation from bypass despite poor ventricular function. Entrapment of coronary angioplasty devices is a rare but life-threatening complication, and failed retrieval mandates surgical intervention. We need careful preparation, then and arrangements of blood products, and CPB also is a crucial plays a crucial role in the management of this thing. Thank you. So we had some challenges in the form of low EF, then global wall hypokinesia this patient has, then hypotension, tachycardia, and most importantly the ongoing ischemia, which was there because of the stuck balloon. And then as it was a redo case, so a lot of adhesions, lot of bleeding. Deranged INR was also one of the component. Then difficult sternotomy was there, so prolonged surgical time and prolonged time from sternotomy to going on CPB. So these are some of the challenges we faced in this. This was the case. Thank you.
Thank you, Dr. Ashwin, sir.
Thank
So
you
over
very
to
much.
chairperson.
You both were present, or you
No.
single-handed managed it?
No, she Purnima is in different setup. Yeah.
Okay.
Mhm.
Okay. Yes,
Kelkar ma'am.
Yeah,
Kalpanam,
it was,
Kelkar ma'am.
Ashwin, it was a really, really difficult and challenging case to manage.
Yeah,
I was wondering how you must have explained to the patient before shifting the patient to the OT. What kind of risk was explained, because it was a tightrope walk, I think.
Yeah. Actually, the cardiologist also played some role in the counseling. So they had briefed the patients and the relatives quite nicely. So a little part of it was carried out by us also.
And what was the induction agent used as? I'm sorry, but I missed it.
We used Etomidet, madam.
That's because the ejection fraction was so low.
Yeah, it was
And
25% with global wall hypokinesia, and this was pre-procedure of the angioplasty. So
yeah.
it might have reduced afterwards.
Yes, yes, yes.
We couldn't put a T because of the fear of the raised INR.
Yeah.
Then
No,
since
any
since
idea?
sorry,
Why was the INR raised?
uh, he was on Clopidogrel, ma'am.
Because of okay, okay. But
He
then
was
reverse the platelet this thing with any injectable agent.
sorry.
Platelet the conversion the what I should say action was not reversed of
Yeah,
clopidogrel.
yeah. We gave no. It was we gave FFP for the INR, 4 FFPs
Okay,
before
okay.
induction. Yeah, and
Because
we
I
didn't do
was-
APTT actually. He had received
Mhm.
heparin for the procedure, 7,000 units. So
Okay. Yeah, yeah.
like this. And since it was emergency, we could not
Yes,
put a
yes,
IABP to offload the heart,
yes,
and
yes.
we didn't get a Schwangen also that time.
I-
It was
Again,
in the
putting the
evening
IBP and
time.
all in an anticoagulated patient, it
That
was
is a problem. Yeah, yeah. But
yes.
we could have offloaded the heart.
Yeah, it was really a nightmare, I must say.
Yeah, and that too in the
Yeah.
evening when the efficiency goes
Oh,
down.
yeah, yeah.
Mm.
Very nice case, very nicely managed.
Yeah,
Congrats.
yeah. Thank you, ma'am. Thank you very
Over
much.
to Madhuri, ma'am.
Yeah, very well managed case as already told. But this case actually is very underreported and very uncommon. So I
Yeah,
think you can report this case
yeah. We are
as a case
preparing
report.
it. Yeah.
And one question is that were any attempts made to retrieve that retained balloon stent assembly? Like, because you
Yeah,
said the decision was taken to go on to redo CABG, right?
yeah. They attempted many times in the cath lab to retrieve from the
Mm-hmm.
femoral end, but
Hmm.
it was just not possible. And then the
Okay.
patient started going sinking down hemodynamically.
Yes,
So
yes.
we need we it was no there's no
Yes.
option other than the surgical.
Yes, yes. It's a potentially devastating complication.
Yeah, luckily
And
we could manage with peripheral this thing, NORAD.
yeah.
The
And
cath
it
lab
also
people.
teaches us that whenever in that no procedure can be taken lightly,
Lightly, yeah.
even in the cath lab, anytime you may
Mhm.
have to go for open surgery. Yeah,
Yes, yes.
very well done. Very
We
well
have
done.
a backup. We
Yeah,
provide backup to the cath lab daily on daily.
correct. So backup is very, very necessary whenever you go for any
Yes.
cath lab procedure.
And
Yeah.
I think, Ashwin, you were really lucky that
Mhm.
the broken end did not tear off the vessel because then
Yeah,
it
yeah,
would
yeah.
be
Yeah,
really,
maybe
really,
they tried a little softly. Had
yeah.
they tried it very harshly, it would have broken it.
Because that
Broken in.
would have become even
Yes, yes.
very, very sinister complication. Yeah.
Yeah. Maybe the
Yeah.
patient would have not reached also
Yeah.
the
Yeah.
OT.
Yeah.
Yes. Thank you.
So coming to the next case, before that I welcome Dr. Manisha Katikar madam, the past GC National and past President Maharashtra State Chapter of ISA. Welcome ma'am.
Sheetal.
Thank you. Thank you so much, Dr. Sheetal. Thanks a lot.
Hello.
Welcome, Manisha. Sheetal,
Yeah, ma'am.
can
Good
you make
evening.
yourself visible? You are behind the curtain, I think.
Did I disturb?
No, no,
You are
madam. She
very.
is seen clearly.
She has joined through 2 devices, madam. If
माझं
you
laptop.
scroll
Oh,
down,
that's why I can't see her face. Okay,
तुम्ही
from my
स्क्रोल
device.
डाऊन केलं ना तर तिच्या
Okay,
वेगळ्या
okay.
डिव्हाइसचा फोटो दिसतोय, चेहरा
Oh,
दिसतोय.
okay, okay.
Now the next speaker is Dr. Shweta Salgaonkar. So she has done MD anesthesia and fellowship in pain medicine. She is a professor and pain physician at KEM Mumbai. Then she started pain clinic and lab in 2011 at Public Hospital. Started MUHS recognized pain fellowship. She is a difficult airway manager. She is a simulation vast facilitator. Since then, she has done workshop for non-technical skills for healthcare workers. It is a medical education that is advanced course in MET and also CBME, and she is a promoter for patient safety and patient care. She has 35 national and international journal and 2 institutional research society grant. At present, she is a president ISA Mumbai Metro. So welcome, ma'am.
Thank you, Dr. Sheetal, for that kind introduction. Somehow, I think my video, I'm not been able to, I've kept the camera open, but I'm unable to show my face. But I hope that's okay. We can start with the presentation. Is that okay?
Yes, ma'am.
Because I should not waste time in trying to get this right. I can't get the video. I think it's okay. So yeah, coming to the good evening everyone, and dear dignitaries, faculty members, and friends. Bring greetings from St. GS Medical College and KEM Hospital that has completed 100 years this year of advancement of medical science and patient care. And I thank SAMS for this opportunity to share this interesting case on this forum. And I'm going to talk about the role of regenerative therapy in traumatic brachial plexus injury, pain, and dysfunctionality. Well, so we talk all about anesthesia, critical care, but this is little offbeat. Not many of us practice pain. So in KEM, we do have pain clinic for last almost 20 years, and we are doing a lot of interventional pain management. So this is one of that case that I'm presenting. So traumatic brachial plexus injuries are disabling injuries with debilitating pain, profound functional deficits that affects the quality of life and cause substantial psychological trauma and economical instability. It also comes with severe neuropathic pain, though the limb is non-functional, the pain is still there, and mostly it is there in the dependent hand that causes dependency on the dominant end, and that causes dependency on the family members, caretakers. This leads to a lot of psychological trauma in the form of depression, and leads to thoughts of amputation and suicide. Like, the patients have come to us saying that anyway, this is a useless and please cut them off. I don't want it. 90% of these patients are generally in their productive age group, where they are the sole bread earners in the family. So they span brachial plexus injuries. Either they are avulsion, which is mostly preganglionic, or rupture, which are generally present as postganglionic. And in the distal nerves, you will see the Wallerian degeneration as a part of the debris removal. So what are the management options that we have? Conservative management is done with supplements of B12 in the hope of regeneration. D3 supplements are given. Some anti-neuropathic medications like gabapentinoids are given to take care of neuropathic pain. TENS, physiotherapy, mirror therapy. So everything, they'll keep that muscle alive till the spontaneous regeneration probably happens, or patients have to be kind of exposed to surgery. But 60% of these patients, they present very late, so the surgical success is also not great. The neurotization, like nerve transfers and grafts, they are limited by the donor site morbidity and slow axonal growth. We know it's just 1 millimeter per day. And the entire event is time critical, in the sense, if the regeneration of the muscles do not happen, of the denervated muscle do not get regenerated in 12 to 18 months, then there will be irreversible atrophy of the motor end plates. And again, it depends on the severity of the injury. We know the Sunderland's and Sedan's classification of the nerve injury. So long gap injury, especially more than 5 centimeters, very difficult to get completely remyelinated. The nerve regrowth is difficult, and this results in poor hand function most of the time. So the entire injury, the brachial plexus injury, requires extensive rehabilitation to improve the arm function. And many times the arm remains dysfunctional, but the pain is still there, and that's why at times we may have to offer them DRES lesioning, that is the dorsal root entry zone radio frequency lesioning is done to take care of the pain. So here we have these two cases who have presented with this brachial plexus injury, and they presented when already 6 months and 9 months had passed, and both of them had moderate to severe kind of brachial plexus injury. And as you see it, the function here, the muscle grading that they've done done by the occupational therapy as per the muscle power. So most of the rotator cuff and the arm muscles are showing all negative to zero power there. In case 1, little better than case 2, but yes, even the range of motions were all totally compromised. So if you see this, that he's trying to move his fingers, unable to do any kind of flexion. So here comes a total dependency on the relatives, unable to do anything. This patient is from Buldana, and both of these patients were deemed not suitable for surgery. So what can we offer to these patients? Already conservative management is given. Surgery is not an option. So being pain physicians, we do use regenerative therapy, which is the PRP, that is platelet-rich plasma, or the growth factors for various indications, commonest being osteoarthritis or tennis elbow, or even for non-healing ulcers, we have seen them, plastic surgeons using them. Even ortho people use it for non-union fractures. We use it for sports medicine, and in muscle tears and strains it is used, and even transforaminal injections for the sciatica and the nerve root compressions. So we thought we could extend this indication to the brachial plexus injury if it can be of any help. So the experimental nature of the management was explained to the patient. So we offered ultrasound guided growth factor injection at the injury site. So that site is the interscalene level where the roots are there, and these are the C5, 6, 7 roots that you see, which are commonly affected in brachial plexus. And so the patient counseling and informed consent were done. This procedure is generally the daycare procedure. It's done under local anesthesia with all aseptic precautions. And the growth factors it is the autologous growth factors. That is the 8 ml of patient's blood is drawn, and it is mixed with this test tube that have some preservatives and some platelet lysis agents. They are the patented kits that we get it. And this particular kit will require 8 ml of patient's blood, which will give us 4 ml of growth factor yield. That is the yellow clear fluid that we see on top is the growth factor. So we did ultrasound guided perineural injection. You can see that this is our classical interscalene approach that we use it. So there were 2 sessions that were performed 1 month apart with 4 sessions of dry needling and physiotherapy. So this is the top layer of GFC, this is the gel, and this is the cells. So this is what we inject is without cells, so there is no pain or inflammation at the site on injection when we are giving it. So these growth factors play very important role in cell proliferation, differentiation, and survival. So what are these growth factors? The platelet-derived vascular endothelial insulin-like growth factors, or even the fibroblast growth factor or epidermal growth factor. So there are various growth factors which help in the nerve regeneration, maintain the microenvironment. So what do? They promote angiogenesis. They improve the microcirculation in the ischemic nerve. They form these bands of Bungner. That is this is precursor to Schwann cells. So once this regeneration starts, first is the Schwann cells. They'll make this bands of Bungner, through which the axon, the nerve, will regenerate, and with its support, it will be able to grow in that particular direction and make a connection. And this also growth factors also down-regulate the pro-inflammatory cytokines. So this reduces the scar tissues that usually block the nerve regeneration. We also offer this dry needling, where these are the acupuncture needles, but they are very fine needles, 30 gauge needles, and there are different lengths which are available. So putting this dry needling, this is also done ultrasound guided. So we target biceps, brachialis. So individual muscles are targeted, seen under ultrasound, and the needles are put. They are kept for about 10-15 minutes, and they are removed. And we give about 4 sessions of this needling in over 6 weeks. And we also give 2 injections of GFC 1 month apart. So this helps in resetting the dysfunctional motor end plate and improve the circulation. So outcomes, as you can see, that this post GFC, whatever, all these we see the highlighted ones, muscles, they show a good positive response here. And the pain score also went down from 7 to 4. In the other patient, 8 to 4. And we see the second patient was actually very severe, and still at shoulder and at the proximal muscle, it showed a lot of improvement. This patient also has lumbricals, entrosia, all the fine muscles are also getting recovered, if we see that. So that is the result we saw with this growth factor injection. So growth factors actually jump-started the stalled process because both the patients had reached the plateau where there was no more response to physical and occupational therapy, and surgery was not an option. So growth factors, they stimulated the axonal regeneration, supported the axonal survival, accelerated remyelination, and modulated the local inflammatory microenvironment to promote the functional recovery. The non-neuronal components are also important to allow the nerve regeneration. We are like the macrophages that will clear up all the debris and reduce the inflammation, the inflammatory markers which are there. So these growth factors, they take care of this local microenvironment and get the right kind of cells so that it helps in regeneration. And so the functional gains are also much faster. So we gave the growth factors at the target directly in the ultrasound guidance that helped us to have that highest concentration at the site of the injury. And of course, so the effect we understood is because of the GFC and not simply as a spontaneous, because it had already reached a plateau. Dry needling helped us to get the vasodilatation and took care of the compensatory spasticity. Ideally, we could have had EMG, NCV done in this patient, but unfortunately, patients were not affording. And of course, these procedures are also painful, so it is difficult to, expose them to these. But we rather relied more on the clinical recovery. So to summarize, ultrasounded USG guided growth factor injection as a part of the regenerative therapy in traumatic BPI can be rewarding for the pain management and functionality improvement, which in turn definitely improves the quality of life. And the target site is interscalene groove, as the common routes affected are the C5, 6, 7. These are generally the daycare procedures done under local anesthesia, and it's autologous blood, so it's much safe for the patient, and it can become an important intervention to facilitate the management of pain and functionality, and it can complement the rehabilitation program. These are the references, and thank you for your kind attention. Thank you for the opportunity.
Thank you, ma'am. Over to chairperson.
Excellent presentation. It was really so rewarding.
Thank you
Growth
so much, madam.
yeah. Growth factor nowadays is, I think, used like right, left, and center in the orthopedic practice. But this
Yes.
is a really rewarding this thing. In Pune, there is one surgeon who is operating on such nerve plexus injuries by doing some nerve transplant. I think there is some connection from the phrenic and that is done, and it gives rewarding results. But I don't know the details
Yes.
of it.
Yes,
Yeah.
madam, definitely.
Yes.
First patient, so this, I work in plastic surgery as anesthesia chief. So there, of course, they do this nerve transfers done very routinely. Every week,
Yeah.
we have at least 3 to 4 patients.
And
But
that is a
these
very,
two,
very long procedure, prolonged period it goes on, no?
yes,
Yes,
it
yes.
takes at least 4 to 5, and they take intercostal nerves and
Yes.
they put it into the muscles so that at least they can eat on themselves, they can wear clothes on by
Yeah.
themselves. So this is the procedure they do. But these two patients were unfit for surgery. The first patient, they said they cannot do anything much because they don't see gross anatomical problem. So it was primarily the functional problem, and they said they cannot do that. Second patient was a very bad smoker. So the PFT came as like unfit for anesthesia. They will try to give this function, but he will be going on ventilator and will have issues. So both the patients were deemed. This is the first two brachial plexus cases where we have injected GFC. So we also were not, but we have done it for peripheral now, madam. Like ulnar
And I
now
think
we have
you
done
should
it.
be presenting, you should be publishing this.
Yes, it's
Yeah.
we are trying to do that. We'll
Yeah.
definitely take it up. We presented recently in Tata Hospital. ECAP conference was there, and we will publish this definitely, madam.
Because
This
it
is
is really
interesting.
having a rewarding result. I mean, I saw some changes in the muscle. This thing was from 2 to 5
Yes,
and
madam.
from 0 to 5. So that is wonderful. That is
Yes, yes.
amazing
And
result.
here
And
they've
what
still come late. I thought if
yeah.
they can present to us early now, we'll have to collaborate with surgeon and tell them to do things. Let's see how it works. Fortunately, I work in plastic, so there is some communication channels open, and if we can make a difference there, definitely we'll
Yeah.
try and.
And what are the risks of this growth factor injection? Any
As
specific
such, as I
consequences?
said, madam, because it is autologous, we just have to handle it with all aseptic precaution. Otherwise, there is hardly any. Only thing is because growth factors, so they are so far not been evaluated in cancer patients and all, where cancer cells can take this up and can grow. So it is kind of relatively contraindicated in these kind of patients.
And is
But
there any role in the central neurodegenerative disorders?
It is all under exploration. There are some surgeons who have already tried stem cell and things earlier, but I think so far those were the early trials that were done. So they have not yet found the right protocol to do
No,
it, but
because
I'm sure
in the central degenerative, where to implant them?
there are some surgeons who have already done it, madam. So there
Yes,
are.
how do the because for peripheral you can understand ki you can deposit it there, but for say like progressive supranuclear palsy or things like that, central degenerative disorders.
So they have some things transcranial also, madam.
Okay,
So
okay.
yes, so they do have, but these are really experimental one at this point of time. So very difficult to
Anybody doing it in India?
India, the cranial ones, and I don't know about the transcranial ones. I can find out and tell you, but I have read it.
Please,
So
yeah, because I wanted it for some patient.
yeah, definitely I'll find out and I'll get back to you, madam.
Thank you. Very nice presentation. Very nice.
Thank you,
Thank
madam.
you, madam.
Thank you. Yeah,
Over
thank
to Madhuri Tudi, ma'am.
Yeah, thank you. And Shweta ma'am, could you have used platelet-rich plasma for this condition?
Madam, this is the similar version only. So platelet-rich plasma.
So can you explain how the this growth factor concentrate is better than platelet-rich plasma in this condition?
Yeah, so I said the platelet-rich plasma, what happens is that we have platelets which are 3 to 4 times the concentration. That's how it is. We take the blood, and that platelet rich plasma requires a drawage of about 40 ml can give you 4 ml of yield. Here just the 8 ml of blood I take and I get 4 ml of yield. Am I clear in this that you require a lot of more blood in PRP? That is one thing. Second thing, it will have the platelets which are intact. So when you inject it into the patient, it will be like any trauma. What happens that platelets are called there to seal the wound. It will further recruit the macrophages and will create the inflammation first. So what patient gets is a 24 to 48 hours period of more pain because there is inflammation, because platelets are going to recruit more cells there. But in growth factor, the platelets are already lysed. So we have only the soup of growth factors, the platelets are not there. So it is kind of ready to eat kind of thing for the cells. They can just pick up the nutrients and the neurotropic factors directly from that soup rather than from the platelets. So the
Yeah.
platelets do not degranulate there and cause inflammation. So patient do not suffer. The patients have come to us for pain, and then if we can avoid pain and that phase, it will be kinder to patient.
And
I
what
think
is
you can easily plan studies of comparing the PRP with the growth factor, right?
Yes, yes,
Maybe in the future.
we
Yeah.
can do
Okay.
that. We can.
Okay. Thank you.
and
Yeah.
what is that substance which is added to blood for this separation of this growth factor?
Madam, that is all. They have their patents. So there are few companies. It's just a simple test tube which is there, which I showed.
But then what is the cost?
It will have it costs anything from 1,200 to 6,000, 7,000, or it's a very variable. But our patients can afford, and generally we get it in bulk. So it is possible for Indian patients and our population.
Okay.
Thank you,
Okay,
ma'am.
We'll
Thank
go,
you.
go ahead.
So coming to the next presentation, we have very young honorary secretary from ISA Jalgaon. She has done her MBBS and DA from KEM Mumbai, and she is a freelancing anesthesiologist in Jalgaon since 2009. She is a member of IMA AMS committee at Jalgaon and awarded by Rotary for anesthesia services for medical mission at Zimbabwe. So over to Dr. Jayashree Rani from Jalgaon.
Thank you, ma'am. Thank you for my kind introduction. Am I audible, ma'am?
Yes, yes.
Yes, yes, very well.
Good evening, SAM's president, Dr. Avinash Bhosle, sir, SAM's secretary, Dr. Sheetal, ma'am, and all SAM's office bearers. Good evening, our today's chairpersons, Dr. Kalpana Kelkar, ma'am, and Dr. Madhuri Kurdi, ma'am. Good evening, all my seniors and colleagues here. I, Dr. Jayashree Rane from Jalgaon, I am here today with my unedited story right from the operation theater, just as you can see me in the pic shown on the flyer for today's webinar. Thanks, SAM's team for giving me this opportunity to present the case on this huge platform. Basically, my case is very simple one, but really a complicated story. Recently, I experienced a case which I managed in the way which kept me more alert throughout the case. My patient, a 22 years old male, posted for laparoscopy for inguinal hernia with TEP mesh repair under GA. All investigations were normal. Patient thin built, tall, athletic, no other comorbidities. Airway showed Malampatti grade 1, normal neck mobility, thyromental distance looked near adequate. Patient had history of lap appendicectomy under spinal anesthesia few months back in the same hospital setup with the same surgical team, including me. All the case was uneventful throughout the intra-op and post-op. The course was uneventful. Now this time, the patient was posted for hernia under GA. After pre-oxygenation, patient was induced with injection pyrrolate, injection midazolam 1.5 milligram, injection propofol 100 to 120 milligram IV. After confirmation of good mask ventilation, scoline was given 100 milligram. Direct laryngoscopy was done with conventional laryngoscope using MAC3 blade. On my surprise, Cormack-Lehane grade 3. It was Cormack-Lehane grade 3. Only epiglottis I could see. Even after pressing on anterior neck, no parts of cords was seen. The larynx was placed extremely anteriorly. I tried to manipulate the epiglottis with ETT with stellate, but I couldn't manipulate and couldn't intubate. Oxygen saturation was maintained throughout the procedure. Again, mask ventilation was started. and SpO2, EtCO2 were monitored, which were within normal limits. Second attempt was done with using McCoy's flexitip blade, but again, larynx was too anterior and I couldn't intubate. Mass ventilation was very easy and maintaining 100% saturation was very easy, with tracings of EtCO2 also present on the EtCO2 monitor. After that, a second anesthesiologist called for help. He also tried, second anesthesiologist, senior anesthesiologist called for help. He also tried the third time direct laryngoscopy, but couldn't intubate. The best thing was that my patient was young, fit, easily mass ventilation was possible. SpO2 was 100%. So we decided to stop here and we avoided further attempts. No bougie tried, no blind poking to avoid airway trauma and edema. Discussions were done with surgical team. Another option of regional anesthesia with TIVA discussed with the team. LMA Supreme 4 was kept ready on the trolley. Surgeon was confident to complete the case with low pressure as it was TEP, total extraperitoneal approach, and if needed, all were ready to convert the case into open surgery. All consents were retaken. After all aseptic precautions, subarachnoid block was given in left lateral position with 26 gauge BD spinal needle with 4 ml of bupivacaine and 500 ml of Ringal lactate preloading. Level achieved was T6. Patient received injection butadol 1.5 milligrams slowly IV diluted. Again, injection midazolam 1 milligram was given. Nasal oxygen was started at a rate of 4 to 6 liters per minute right from the start of the case. Ketofol was given 50 milligram of ketamine and 50 milligram of propofol diluted slowly for TIVA. Ryle's tube was put to decompress the stomach, and LMA Supreme was ready on the trolley, but it was not used. Laparoscopic TEP repair for left inguinal hernia was done in 1 hour 20 minutes with 10 to 12 millimeter of Hg pressure. Heart rate was 60 to 70. NIBP was within normal limits, 110 to 70. SpO2 was monitored. SpO2 was always 99 to 100. No desaturation. Respiration was spontaneous. It was 12 to 14 per minute. Airway reflexes were intact. EtCO2 35 to 42 all continuously maintained throughout the intra-op. Intra-op course was uneventful, and then the patient shifted to recovery room. Documentation about difficult airway was done on the discharge card, on the papers, and explained to the relatives post-operatively. Here, why I feel I did this correct way. Some points I want to mention here. Avoided airway trauma by stopping after 3 attempts in this patient. Secondly, my surgeon was confident about his surgical time and about my work in regional anesthesia for lap surgeries. I already had done good number of lap cases under regional. Even this same patient we operated under spinal anesthesia a few months back. Continuous nasal oxygenation prevented desaturation and gave us time to act if needed. LMA Supreme was always there for ventilation. Gastric drain with high seal pressure if needed. Having it ready removed the panic situation. The next thing, what if such situation I face again? So what changes I would like to make? I would like to stop after 2 to 3 attempts, early call for help, nasal oxygenation continued, regional for infraumbilical laparoscopy if mass ventilation is easy and patient is ASA grade 1. The most important would have kept me continued with plan of GA. So after this case, I inquired about video laryngoscope, got opportunity for the demo of video laryngoscope. Then, but still I was not convinced that video laryngoscope will always help to intubate such anteriorly placed larynx, because what I have seen, I could not show you here because I was unable to take pics of the Cormac Lehane grade 3 and the larynx. Video laryngoscope definitely helpful in large short neck and reduced neck mobility. Definitely there is a learning curve with video laryngoscope. Probably I will upgrade with this in the coming days. But at least LMA Supreme is must in all OTs. Even if not used, it gives psychological assurance. I think this is the way I managed my case. Thank you very much.
Thank you, Dr. Jayashree. Now over to chairperson.
Jayashree,
Yes, ma'am.
you said that the previous anesthetic exposure for laparoscopic appendicectomy was uneventful.
Yes, ma'am.
Did you refer to the notes again after finishing the surgery, the previous surgery
Ma'am,
notes?
I was the anesthesiologist that time also, so I remembered the case very nicely.
What happened in between this time where the larynx became so difficult to visualize?
Madam, that time it was regional, and that time I didn't try direct laryngoscopy.
It was not
Straightforward, I went by regional way. But this time, the patient is a medical student, second year medical student. This time, he who demanded me, I don't want subarachnoid prick. So, is it possible that I get general anesthesia? So I said yes, it's possible, and directly I asked. I mean, I put the case for general anesthesia, but
Really,
I didn't expect this much anteriorly placed larynx. And in a young, fit, tall, higher patient who was just 20 weeks with mouth opening Malampatti grade 1. So this was really unanticipated difficult intubation for me. In my whole life, I have never seen such a difficult intubation.
I think if you still are in contact with this student, if he is a student,
Yes.
so could you give a try with the elevated, like we do in morbidly obese patients, ramp position? If you can do the indirect laryngoscopy with ramp position, if you can visualize the larynx, just out of interest, I'm asking you to do it.
Yes, ma'am. Out of it, that's why my question was, what advice should I give this patient? Should I take a ENT opinion or any?
I think his CT can be done.
Yes.
Yeah. So that will highlight what are the problems in intubation.
Yeah. This case we did some 15-20 days back. So right now he will come for follow-up. After 1 month, we have decided we will tell him to do flexible.
Video laryngoscopy definitely help. And secondly, what I wondered, it was just a laparoscopic hernia repair. So
yes,
the surgeon could have opted, because hernia is not a very big scar or anything. Nowadays, there is a fashion of laparoscopic hernia repair.
Yes.
But
yes.
done the hernia repair, just routine hernia repair under a regional, where all the
yes. Surgeon didn't insist me for GA because the patient asked me.
No, but that is okay. But then when you can't do it, then you have to resort to a safer practice, no? So then why insist on a laparoscopic repair? That's what I'm saying. Just an open repair.
Because I have given anesthesia, regional anesthesia for more than 1,000 laparoscopic cases in this setup with these surgeons.
So, very, very routine thing to do, but then there is a difficult intubation expected.
Yes.
So then
LMA Supreme was there, and we discussed that if needed we will convert the case to open at any time.
Yeah, right. Okay.
Such consent was taken. I mentioned in my talk, the consents were retaken and the relatives were explained all the risks, and after that only we proceeded for the case. And the patient had come to home in his holidays for this. Yes, ma'am.
Does this patient have a very prominent Adam's apple?
Yes.
Long neck and prominent Adam's apple. Sometimes these patients have anteriorly placed larynxes.
This was really a nightmare for me. I was not expecting such a difficult anteriorly placed larynx, and even a senior anesthesiologist couldn't intubate.
Why you have
I just
given
want to
Tiva?
ask, can I
Yes.
say something?
Yes, yes.
Yes.
Madhuri,
Do you
over
have
to
that
Madhuri, madam.
flexitive laryngoscope? Flexitive.
Yes. Flexitip,
With
McCoy's
that,
Flexitip
yes.
bib. Yes, I used, madam. Second time I used Flexitip bib blade.
Because
Over
that
to
helps a lot.
Even with that Flexitip blade, I couldn't visualize the chords.
Okay.
Why you
With
have not done the
Gucci,
case under regional only?
sir,
You
sir,
given Tiva.
Not lyrical.
patient demanded, this time he wanted general anesthesia. He is
No,
the
no.
second year medical
No, after
student.
after
He
failed
demanded me
intubation.
this time he wants general anesthesia.
No,
Yeah.
after failed intubation.
They
Done
intubate.
under regional.
The
Yes.
student has been convinced.
Huh?
After failure of intubation, the
Uh-huh.
student has been convinced.
Why you have given Tiva?
Sir, for
You,
laparoscopy, we need to
under
give some
sedation.
amount of Tiva.
No. You can do it under regional plus sedation only. Why propofol and ketamine also given?
Sir, after pneumoperitoneum, some amount of shoulder discomfort is
No, there
always
is
there.
there was no pneumoperitoneum. It was extraperitoneum only.
Sir, it was TEP, but unaccidentally, peritoneum was open. Accidentally, peritoneum was open and pneumo was done. Pneumo was created accidentally. It was not planned.
Even that every patient don't require any. It will manage by sedation also. I am doing these cases in 2002. Even laparoscopic cholecystectomy under regional. We give a diaphragmatic instillation of 2% dilocan and bupivacaine, 10 plus 10 ml. It gets.
So this is before pneumo, means just after creating pneumoperitoneum, we instill this.
Yes.
Over to Madhuri, madam.
Okay. We instill this at the end of the surgery for post-op analgesia.
Yes, Madhuri, could you, ma'am?
Yeah, I think Dr. Jayashree, you can
Yes,
call
ma'am.
this patient anyway. She's a medical student, so you can do ultrasound of the airway. Nowadays,
Okay, ma'am.
ultrasound of the
Yes.
airways is very commonly done. Find out the various
Okay.
distances and parameters, and
Yes,
you
ma'am.
will be able to find out more details about her anteriorly placed larynx. And one
Yes,
more thing
yes.
which you could have done is already the video laryngoscope has been discussed, but
Yes.
you had adequate time. The surgeon was ready to wait, right, to proceed with the surgery. You could have gone with fiber optic bronchoscopy and also maybe hybrid technique with video laryngoscope and fiber optic. You could have even intubated through the LMA Supreme, which you said you had kept as backup.
Yes.
So you had some various other options
Patient,
also, but it
patient
is
and relatives.
they were not ready. Okay, it's okay. You changed to regional is a very
The
good thing.
patient was there. Patient was there for 3 to 4 holidays from his college, and they were easily accepted. Last time we did this same case under same laparoscopy case under spinal, so this time you can continue with the spinal, so no problem.
No,
So
no,
we
that is
continue.
okay. Patient
Yeah.
agreed it is okay, but these were the other options which you could have
Yes,
utilized.
we
Yes.
discuss all options, ma'am. We discuss
Yeah.
about postponing of case, we discuss about fiber optic, we discuss about video laryngoscope availability, but we decided to continue with the case because we were confident enough. We will finish the case in regional.
Okay. It is best to take up a technique in which you are most confident in. That is very important.
Yes, yes.
Yeah.
Thank you,
Can I
ma'am.
comment? Dr. Sheetal, can I comment?
Yes,
Yes.
ma'am.
Yeah. Usually in this case, I found that video laryngoscopy with a bougie can do the trick. And the video laryngoscope, you have to get used to it. Like you can't use it in first time in a difficult case. So if you are used to video laryngoscope in a normal patient, you will know the nuances of using a VL scope. So if you are used to using VL scope and just behind the epiglottis, just thread the bougie and railroad the tube. So I have been able to do it most of the times with the bougie and a VL scope.
Yes, ma'am.
the anterior larynx. What
Thank you, madam. Going for the next case,
Yes.
because we have two cases. So the next speaker is Dr. Farzin Qureshi. Now I request Dr. Shilpa Tivaskar to introduce her.
Yeah, it
Shilpa?
gives immense, yeah, I'm there. It gives immense pleasure to introduce my colleague, Dr. Farzin Qureshi from ISA Borivali. She's editor of ISA Borivali Bulletin. Madam is MBBS Nair Hospital, MD Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, and she has done European Diploma of Intensive Care. She's a senior consultant and anesthesiologist at Wockhardt Hospitals, Mira Road. Madam has major achievements, university topper at MD exam, best postgraduate teacher award by AN by at gold medalist in anesthesia patient safety course, and winner of state level orator award in school, and winner of multiple quizzes and competition, and best poster award in Yuva Mahakon. And Madam was scientific secretary, joint scientific secretary of BSECon. We welcome you, Dr. Farzin. Over to you, Dr. Sheetal.
Thank you so much, ma'am, for the kind introduction. A very good evening to SAM's President Avinash sir, Secretary ma'am, Sheetal ma'am, Shilpa ma'am, Kalpana Kelkar ma'am, and Madhuri Kurdi ma'am, everybody. It's an honor to be here on the SAM's platform, and I've been waiting for this opportunity since a long time. I will share my screen and let me know if it's visible.
At the bottom of your
Share screen. Did you see the option, Dr. Farzin?
Yeah, I can.
Have you opened your PPT at back?
Yes, ma'am.
Yeah.
I have.
Yes, it
we
is
can
good.
see.
Yes,
We
yes.
can see, yes.
Okay, great.
Now just make it full screen.
Yeah.
From the icon at the bottom of your PPT. Okay, from wherever, yeah.
From beginning you can.
Is this okay?
From we
Just
have to
zoom
click
it.
from
There's
beginning.
Oh, okay.
You have to click slideshow, then from beginning.
Or if you see the icon below your PPT.
Go to slideshow and start from beginning.
बराबर है.
Okay.
Okay.
Yes,
yes.
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 Okay. So this is a very basic case of rheumatoid arthritis patient, but the patient landed up with us with a very challenging supraglottic mass. So initially the patient came to the PAC OPD. She had some hoarseness of voice and she was not evaluated. So we just took it as a rheumatoid arthritis and we just evaluated the neck, and the neck movement seemed okay, and we thought that the rheumatoid arthritis has not compromised the air too much. But once we am I audible, ma'am?
Yes,
I
you
am-
are audible. You just continue. There is disturbances from the
Okay.
audience.
Oh, okay, fine. So later on, when we got the CT picture that it was a supraglottic mass, we immediately began to worry, as we always do. So the baseline of the patient history was she was a 74-year-old female. She was a known case of rheumatoid arthritis and she was a hypertensive. She presented with a 4-month history of a sudden onset progressive non-productive cough and severe hoarseness of voice. It was associated with weight loss and loss of appetite. So she So the CT neck, directly I will go to the important investigation. It revealed a mass measuring approximately 2.8 into 2.3 centimeter. It wasn't a very big mass, but it was the location which made it tricky. So the location was from the root of the trunk to the free edge of the epiglottis. It was almost overhanging the glottic aperture, but not fully covering it. The glottic aperture could be seen as a thin tube passing in the CT scan, and the superior to inferior length was 1.3 centimeter. So this was the preoperative evaluation of the patient. Since the patient was thin-built, poorly nourished, and she had pallor, we assume that she had reduced the physiological and metabolic reserves. She was not even 50 kg in weight, and her airway assessment made she had adequate mouth opening, but her Malampatti classification somehow was class 4. The neck mobility was fine. So we anticipated that it's going to be a difficult airway visualization. But her mouth opening was like 3.5 to 4 finger. And she had presence of swan neck deformity of the fingers, and that was because of the severe chronic systemic changes of the RA joint. So we could expect that the cricoarytenoid joint also may be a little bit hampered because of that. So she was anemic, and as she had pallor, so again we took it as a negative indicator, considering that she could have reduced oxygen carrying capacity and her apnea time would be not very great. And cardiovascular wise, she was okay. She maintained pulmonary artery systolic pressures of 30, and her hypertensive heart disease was evident with the concentric LVH, and that again pointed that she couldn't be tampered with a lot of hemodynamic disturbances. She could have hypertensive crisis, and in the chest X-ray was significantly unremarkable, more or less, and she had an altered baseline lung compliance, which was not very significant on PFT, and the CT report showed some parenchymal tissue changes, which were again not significant. So discussion went on between what could be the anesthesia plan. So we discussed it with our ENT surgeon, and what he just wanted a small piece of a biopsy. He didn't want to remove the tissue. He didn't want to do any total excision of the mass. He just wanted a small piece of, a piece of the tissue for just a histopathology monitoring. So we discussed it with the patient's relative, and we told them that we would probably be intubating her with a fiber optic laryngoscope, and more or less she would have probably go to for the ventilator for the post-operative period. But the relatives were failing to understand the criticality of the situation, and they continued to ask questions about why do you all want to put the patient on ventilator if it's just a biopsy. So it was a very painstaking discussion. It went on over for 2 days, and the ENT surgeon, on the other hand, kept on saying that it's a very small tissue and we need not anesthetize the patient at all, and he can just do it with a standby with some local topical spray of 10% lignocaine. So after a lot of hustle and bustle, one of my colleague, Dr. Gayatri, and myself, we decided that we have an adult fiber optic scope in our institute, which we think that if it touches the tumor in the supraglottic area, it would block the vision, and then it starts bleeding, and it's a friable tissue, and then we cannot see anything further. So we held back with the fiber optic principle. What we could have done was used a fiber optic and done a check video laryngoscopy, like a hybrid technique, as Madhuri ma'am suggested a while ago. But that we didn't do because of then we would have to actually book the fiber optic, and we had not booked the fiber optic for that day for some other reason. So we thought that we will give the patient a trial of small general anesthesia dose with a propofol with a chexcopy without any muscle relaxant, and if once we put a small microlaryngeal tube, we can allow the ENT surgeon to take a biopsy, and then we would extubate. Even though the surgeon didn't want us to put the tube in the first place, he said it's going to be a small pick, but we all know that we cannot trust these small picks, more or less. And he also said that I can do it with a rigid laryngoscope under topical anesthesia with a standby. So these were the two plan of actions that we had thought of. So we briefed the team, and we have residents, and my colleague and myself, we had a multi-departmental case brief, and ENT and ICU teams were involved. We had to keep the ICU in loop because we were not expecting the patient to get extubated also easily, because that also was a challenge. So comprehensive high-risk consent was obtained from the family, detailing the possibilities of complete airway loss and severe aspiration and mechanical ventilation. And last but not the least, emergency surgical tracheostomy was also explained in brief. So this was the laryngoscope. This was the CT picture. I think this was the most accurate cut which I could get. So if you can see, appreciate here, just below the epiglottis, the mass is just sitting right there, and the chink is hardly very low. It was like just maybe 2 millimeter chink was remaining between the posterior pharyngeal wall and the base of the epiglottis. So we decided to start with hydrocot 100 mg and lignocaine adrenaline nebulization to constrict the tumor vasculature and desensitize the mucosa. It was a fully equipped difficult airway trolley, including a microlaryngeal tube and rigid laryngoscope, and induction hydrocot 100 mg was given in the beginning. And towards the once we started the case, we made sure that the fiber optic also was getting arranged. So we used the patient with an IV midazolam of 0.5 and 50 mics of fentanyl and only 100 mg of propofol. I didn't give a very less of propofol because then the patient would struggle, and if the patient struggles, then you'll end up touching the tumor with the blade or the tube and the catastrophe happens. So propofol was not too less and not too much. And we used a video laryngoscope which we have in our hospital, a Mach 3 blade on that, and it was a moderate sized pliable region. It was seen extending to the aryepiglottic fold, right more than left, and also extending to the pyriform fossa. The laryngeal chink was also visualized as a dark hole. It was deviated to the left side. The plane of anesthesia was deepened and the full 100 mg propofol was given. Initially, we gave only 50 to 70, then we deepened it to 100. Then a stillet was inserted in the microlaryngeal tube, and through it, along with the stillet, I mean to say, the microlaryngeal tube of 5 millimeter was guided into the trachea, and it was secured appropriately. Sorry. And during the intubation process, the mass started to bleed a little bit, and it was controlled using small suction and adrenaline patties that the surgeon had kept ready with the VL scope. And with that VL scope, after securing the airway, after the tube was inserted, we gave rocuronium 30 mg and sevoflurane and air oxygen mixture was started. The patient was hemodynamically stable, and the surgeon landed up taking a forceps biopsy with the videolaryngoscopic view itself. He didn't insert his own scope. The videolaryngoscope view was enough for him to take the biopsy. So this is the what it looked like. The friable mass on the right with the tube in situ, and this the second picture is showing the mass in more detail, and the tube is right down there. So this is after the intubation, the VL scope view, and how he took the biopsy from it. And then the towards the end, what we did was the patient was transferred, intubated to the ICU for elective postoperative ventilation, because we are worried that the patient gets some spontaneous attempt, then the tumor will have some ball valve recurrence, even though it was not so much on the glottic aperture, but localized airway edema and all were there, and we wanted it to settle because before we extubate the patient. And we did a controlled weaning. After 1 hour of stable mechanical support, the patient achieved good tidal volume. It was anyways rocuronium was given. We could have we had just had to give Sogamadex, but we held on to the Sogamadex. We shifted the patient to the ICU, and full consciousness was attained. Patient was made in the fully sitting position, and after immediately once we gave the Sogamadex and we extubated the patient, gave Duolin Budicort as nebulization and supplemental oxygen via Hudson's mask at 4 liters per minute. And the patient was safely discharged home the following day, completely stable and maintaining 98% SpO2 and room air. So this is the patient post extubation. So I wanted to stress upon this part, because what usually happens in our hospital is the critical care team and the anesthesia team are different. So whenever we have any patient whom we want, if we plan an ICU, then we just hand over the patient to the intensive care and we go back to our cases or go back home or something like that. Because most of the times we don't have too much say in the intensive care management per se. But my colleague has worked in she has worked in a small town setup, and so she suggested that even if you go to the if you want the patient to have like a real speedy recovery, and if you want the patient to feel that it's a small biopsy, and we actually took the trouble to not put her on a full day support, because most of the times what happens when the patient is shifted to the ICU, they put the patient on relaxant and fentanyl and they'll extubate only the next day morning. So we took time out for this patient. We went to the ICU. We made sure that none of these things were given, and we held on to the patient till we extubated the patient, and then made the relative see, and then stabilize her, and then we left back to the OT. So that was an additional thing which we do, because other hospitals and smaller hospitals, maybe it's a routine for them. For us, it was a different step that we took for this patient. So the take-home message which I wanted to share about this case was that definitely a hybrid technique would be better, or a safer FOB technique would be better. But just doing a chexcopy with propofol if for a small biopsy and then securing the airway can act with under relaxant after securing the airway relaxant giving can be really beneficial for some patients. And prior mapping of the tumor dimension is very important, and consultation with the ENT surgeons in planning the physical tube passage and where the trajectory could land, and what all other complications that can be expected, along with the tracheostomy setup ready. All this has to be standardized, and then you can actually take a call with doing this kind of check laryngoscopy. Standard endotracheal tubes may be too wide or rigid, and they having a small diameter microlaryngeal tube readily allows the passage through an asymmetrical narrowed laryngeal chink, and then there is enough space of the surgeon to do his work around the airway. And the pharmacological shielding is very necessary. We made sure that the patient got IV steroids, ligno, adrenaline nebulization. The extubation, the threat of a mass does not end with the surgery. It can cause total glottic shutdown during extubation if the patient goes to breathe spontaneously with huge tidal volumes and great efforts. Then fresh bleeding can also occur. So reintubation under emergency conditions for such kind friable mass with bleeding is nearly impossible. So everything has to be taken care of in advance. And vigilant team communication is important. Pre-induction high-risk counseling with the family is of utmost necessity, and it reduces the panic with the family. Thoroughly, we brief the ICU team that we would like to be bystanders in the extubation of the patient, and we would like to provide our we politely approached them and we told them that we would like to provide an hour or two of anesthesia support for this patient's recovery, and they gladly agreed. Otherwise, it's never this smooth in our hospital, and that is important for a seamless transition, and it prevented any mortality, morbidity, and handing over issues of the patient. So
Thank you, Dr. Farzeen. Very
Yep.
nice presentation. Over to chairpersons.
Yeah, Farzeen, extremely good presentation. I think it is a result of a very good teamwork. You had taken enough pains to discuss, to anticipate the problems, to discuss with all the colleagues. And what I liked most was the delayed extubation and the way the extubation was handled, because I have worked both in the anesthesia department and in the ICU. So I fully agree with you, whatever you talked about the extubation protocol. And it is extremely good to have the anesthesia team which has managed the case at the time of extubation and very rightly managed. Very good. Congratulations. Because
Thank
this
you,
is a very
madam.
tricky scenario.
Over to
Yeah.
Madhuri, madam. Hello, Madhuri, madam.
Thank you. Yeah, thank you, Dr. Farzeen. Very, very, very complicated case you have managed very well. And did you use this 3D imaging for your case?
On the CT scan, you mean, ma'am?
Yeah.
No. I mean, at least
Okay.
I didn't get to see it. Maybe my ENT surgeons would have done because we do have the
Yeah.
3D scanning done.
Yeah, because
But
in this particular, I think these kind of situations, 3D printing and virtual bronchoscopy and all, they're very useful because they can give you a very nice idea about the extent of the mass and the growth.
True, true.
And what would you, luckily the bleeding stopped. You said the mass started bleeding, na, when you
Yes, yes.
tried to injure. So luckily it stopped bleeding with topical, what did you use? Topical
Adrenaline patty they had kept
adrenaline,
ready
huh?
for the surgery,
But
ma'am.
what would you have done if it would have continuously bled? Like there are high chances, no? That also can happen.
Yes, ma'am. Yes. Actually, the tube was in place
Mm-hmm.
smoothly. After that,
So at such times, it is most important to first secure the tube.
yeah,
And luckily your tube was already in place by the time it started bleeding.
started bleeding, right.
Yeah. But if it continues to bleed, then I think they could have tried measures like thermal ablation, isn't it?
Okay.
Or
Right.
maybe balloon tamponade, something like that. Yeah, but
Yeah.
anyway, everything got over smoothly in your case.
Yeah.
Thank you, madam.
Thank
Coming
you,
to the
ma'am.
last case. So the next speaker is Dr. Poonam Ghorki, madam. Now I request Dr. Avinash Bhosle, sir, to kindly introduce Dr. Poonam Ghorki.
Yes, it's my pleasure to introduce Dr. Poonam Ghorki. Ma'am, she is a MD DNB and Senior Consultant at Dinanath Mangeshkar Hospital and Research Center, Pune. She is ex-professor, SKNMC and GH Pune, BGMC nomination 2017 for the best research publication. She got IIC Appreciation Award by SAP, that is Society of Anesthesiologists Pune, 2016, 19 and 2023. GS Ambedkar Award and Srimati Bhagirathi Award in 2007 for academic excellence. She is honored with Best National IJA Reviewer Award in 2020-22, Lakshmi Kamath Award in 2021, and winner of essay competition at various conferences. Prajna Trophy for Best Paper at National Research Conference 2020. Publication and research, she had done more than 35 publications with 6,055 citation in national and international journals. Welcome, Dr. Poonam Ghorki, ma'am, and over to Sheetal.
Yes, thank you, sir, for the kind introduction. Can I share my screen now?
Yes.
I hope
Yeah,
the
it's
screen is
visible.
visible.
Yes, it's visible.
And I have made it full screen. Is it full screen now at your end? Or is it
You have
not?
to do slideshow.
Is it now full screen?
Yes, yes.
Yes. So thank you so much, all the office bearers of SAMS, and good evening, everyone, all the dignitaries and respected chairpersons and my dear friends. I would like to thank SAMS for giving me this opportunity to present the case, which is titled The Neuro Monitoring Paradox, Preserving Signals Without Losing the Pulse. So the case is about the anesthetic management of cervical laminoplasty with neuromonitoring in a patient with moderate aortic stenosis and baseline bradycardia. So to introduce my topic, we all know that neuromonitoring has become an integral part of major neuro and spine surgeries. It gives us a real-time assessment of the spinal cord and neural integrity. And over the years, it is now established with evidence that total intravenous anesthesia is a gold standard modality for doing such cases. Coming to our patient, he was a 74 years old male patient weighing 90 kgs with a BMI of around 35. He was diabetic and diagnosed to have cervical spinal cord compression, for which he was scheduled for a cervical laminoplasty with instrumentation fixation through the posterior approach along with neuromonitoring. So a PAC was done and clinically he looked all okay. The labs were normal. However, on clinical examination, he was found to have bradycardia. So he was subjected to further cardiac evaluation. And the bradycardia was confirmed to be sinus bradycardia on ECG. The PR interval was around 200 milliseconds, and the cardiologist labeled it as an early first degree AV block. On 2D echo, he was seen to have moderate aortic stenosis, mild mitral aortic regurgitation, and the ejection fraction was 45, which was kind of unreliable in the presence of a regurgitant lesion. There was left ventricular diastolic dysfunction. The LA was dilated with a dimension of 5.2 centimeters square. So when such patients are informed to us on PAC, we do a problem mapping so that we understand the problems of the patient so as to formulate the anesthesia strategy. So what were the problems in this patient? So the first problem was obesity, which comes along with difficult airway in itself. Plus this patient was posted for cervical spine surgery. So we know that cervical spine would need an immobilization, adding to the difficulty further. Then obese patient in prone position, the circulation is hampered, the ventilation is hampered, and there are so many other concerns in obese patients. The second was the neuromonitoring. We all know that in spine surgeries or neurosurgeries, whenever there is neuromonitoring, the anesthesia has to be tailored in such a way that a menu is provided which is conducive for the neuromonitoring. So you have to preserve the signals while maintaining optimum surgical conditions. Lastly, and more importantly in this patient was the heart. So he had bradycardia, which made the patient prone for any bradyarrhythmias, and we had to keep pacing and chronotropic support ready. Also, he had aortic stenosis, which means that he had a fixed cardiac output, more so because of the limited stroke volume. In addition, he had bradycardia, so we had no way which can improve the cardiac output further. He had LVDD and dilated LA, so we had to take care of the fluid overload also. So what was the problem? The crux of the dilemma was the neuromonitoring, because without the neuromonitoring, this patient would have been just an obese patient with cervical spine and a moderate cardiac compromise state, and we often do such cases. We all know that with neuromonitoring, the drugs that are available for TIVA, for example, if you decide to use high-dose propofol stand-alone for TIVA, it is certainly going to cause hemodynamic instability and bradycardia. Remifentanil, even in therapeutic doses, is known to cause bradycardia. Before the availability of remifentanil, we used to use dexmedetomidine, and it is relatively contraindicated in bradycardia and has to be used with very caution if the patient has block. Volatile agents may be used with less than 0.4 MAC, but we did not wanted to add one more variable in an already physiologically challenged patient where the MEP monitoring was mandatory. Relaxants is out of question. So we were thinking, how do we preserve these signals without compromising the hemodynamics in this particular patient? So why did I choose this particular case to present here? We do a lot of challenging cases day in and day out. Just a day before, I had a case, a patient whose weight was equal to the ejection fraction. Unfortunately, it was merely 35. But there is a reason why I chose this case instead of that low ejection fraction case. This case made me pause and think about the protocol that we follow for such patients. So we do plenty of neuromonitoring cases, and we have a set protocol where we already know what drugs we are going to use, how we are going to use, and when and what things are to be done. This particular case, because of the physiology, there was a conflict between the protocols and the physiology, and hence clinical judgment became very, very important. So let me walk you through the thought process. So Dr. Samir Ghotawdekar was also there with me for this case. So we both jointly tried to have a conversation with the surgeon that whether really neuromonitoring is necessary. So which of course he said yes, not only for objective assessment, but also for medical legal reasons. So we knew that TIVA has to be given. We knew the limitations of the drugs that are available. And we knew that we had to add a new adjunct or another adjunct in this case. So we boiled down to using ketamine. Now, ketamine is established for TIVA, but in neuromonitoring, it is known to be used only in bolus doses. So I have myself used ketamine very occasionally for neuromonitoring cases, but only in bolus dose, very sub-anesthetic doses, for example, anywhere between 15 to 20 milligrams. But here we were thinking about starting a ketamine infusion. Now, how that would help? So certainly because it is an anesthetic adjuvant with potent analgesia, it would decrease the requirement of propofol as well as remifentanil. So the bradycardia associated with remifentanil will be less because of the decreased dose that would be using. Also, ketamine itself has an inherent sympathomimetic effect, which will help in preserving the heart rate. And also importantly, it preserves the MEP quality, or rather it accentuates the signal fidelity, which becomes good for the neuromonitoring purposes. So what were the anesthetic goals in this patient? To maintain the coronary and the spinal cord perfusion because they wanted to preserve the neural integrity, to prevent any worsening of bradycardia, to preserve the signals for neuromonitoring, to maintain adequate depth of anesthesia, and to be prepared for any CV, that is cardiovascular collapse. What was the management strategy that we formulated to do this case? So firstly, we decided that we would be using invasive lines. So arterial monitoring for beat-to-beat monitoring of the PP, and also a central line to give vasoactive drugs and to also monitor the CVP because we wanted to prevent the fluid overload. To keep temporary passings applied to the patient, to keep vasoactive drugs ready, especially adrenaline, isoprenaline, to overcome the bradycardia. And if at all there is any hypertensive surge, we had decided to use NTG because it would cause tachycardia, which would be beneficial for this patient. We decided to use all the standard ASA monitoring along with temperature, urine output, etc. How did we really conduct the anesthesia in this patient? So after a proper written informed consent and explaining the patient and to the relatives the need of ICU, we went ahead with the case. So I did try giving glycopyrrolate. I could not leave the temptation of seeing how the heart rate responds. But even after the full dose of glycopyrrolate, the heart rate just rose from 42 to 44. This was followed by applying infusions of remifentanil and ketamine and giving an induction dose of etomidate. So around 8 milligrams of etomidate was given. And intubation was done with CMAC using inline stabilization. There was no neck movements. We inserted a flexometallic tube and bite blocks because neuromonitoring was involved. There was no relaxant given whatsoever, neither for induction nor for maintenance of the case. That is how we generally do these cases. Propofol infusion was started once the tube was in situ and the hemodynamic stability was confirmed. Baseline neuromonitoring was done in the supine position, which was acceptable, and then the prone position was given. This is the triple agent technique that I am talking about here. I am not going to dive deeper into the TCI models or the algorithms that would be beyond the scope of this presentation. But believe me when I say that because of ketamine infusion, the doses of remifentanil and propofol were decreased remarkably. So ketamine that we use, which is the star in this presentation, we formulated 100 milligrams in 50 ml. So it was 2 milligram per ml concentration. And we gave anywhere between 7 to 10 ml per hour. So nearly around 15 milligrams per hour was given. The total surgical time was 3.5 hours. There were no major bradyarrhythmias or hypotension. Neuromonitoring was done, which was acceptable all throughout. We did not apply any BIS monitor ourselves, but the BIS was derived by the algorithm used by the neurophysiologist through the EEG. And the derived BIS was always between 40 to 50, meaning that the depth of anesthesia was adequate. For pain relief, we gave, the surgeons gave local infiltration analgesia and we gave paracetamol. Towards the closure at the end, we stopped the ketamine when the surgeon started closing. We tapered the propofol and closed it once the closure was completed. Remifentanil was continued till we made the patient supine. We only tapered it. In the meantime, we gave fentanyl of 60 micrograms to counteract the hyperalgesia that is associated with remifentanil. And then the patient was extubated. This is an intraoperative picture, which is showing the monitoring the heart rate of 43, saturation is good, ATCO2 is coming, CVP, BP. So the BP was perpetually kept between 90s, in the range of 90s. The map was in between 90s for spinal cord perfusion. And you can also see the temperature monitoring. So to discuss this case had a conflicting goals to achieve. The neuromonitoring demanded TIVA, but the patient's heart argued against the conventional TIVA components. So when the standard anesthetic recipe conflicts with the physiology, you need to change the recipe simply because you cannot change the physiology. And the conundrum in our patient was resolved not with the new protocol-driven practice, but in rediscovering old pharmacology. So we had a drug which is one of the oldest drugs in anesthesia, that is ketamine. And at the same time, on our platter was the new kid on the block, that is remifentanil. So it was like synergy of two eras used as infusion. So the take home message would be, we are generally having a fixation over our ideas which become the habit, and we do not want to come out of the comfort zone because that is what is giving us success. But one such off case, and you need to move from fixation to reflection and treat each patient individually so that your natural intelligence predominates over the AI. So every patient is different. Every physiology demands a different plan. With that, I conclude my presentation. Thank you so much. One sentence, no algorithm can fully account for the complexity of an individual patient. So treat every patient individually and have a customized plan. Do not rely too much upon the AI, although I have taken the use of AI for making this PPT. So use it wisely. Thank you so much.
Thank you, Dr. Poonam. Excellent presentation. Over to Chairperson, Dr. Kedkar ma'am.
Yeah, Poonam, it was a fantastic presentation with a very good take home also. But I was just wondering if the pulse rate was only 43, why the cardiologist did not think of putting any transvenous pacemaker?
Yes, exactly. So we took a cardiologist reference because the patient was apparently asymptomatic. Now that we have to probably take with a pinch of salt, because for the past 6 months, he was kind of bedridden and did not ambulate much because of the gait imbalance. But because he put it in black and white that pacing is needed, a Holter monitoring is needed, but that can be done after the surgery. So we had to accept it and go ahead. That happens.
So still the physician domination remains, because on-table bradycardia was not a very good
Exactly.
thing to have in all this, but very
Yes.
well managed. Very good.
Thank you, ma'am.
Over to Madhuri madam. Madhuri madam, we
Yeah,
can't
Poonam.
see you.
You
Madam,
can't
तुम्ही
see me?
Hi,
दिसत
madam.
नाही हा.
Hi,
Arey,
madam.
Okay. So, Dr. Poonam, very good presentation. You can hear me now?
Yeah.
Very
Yes,
good
ma'am. Yes.
presentation. So, ketamine really is an evergreen drug. And would you suggest, now with your experience, would you suggest the routine incorporation of ketamine-based anesthesia regimens during evoke potential monitoring in monitored neurosurgery?
I would not, madam, because generally with the routine doses of remifentanil and propofol and using them as Tiva, it is generally not necessary.
No, and
Unless,
secondly, may I add, because
yes, ma'am.
ketamine might interfere with the sensory evoked potentials, it's considering its pro-convulsant action and its precipitation of the epileptogenic stimulation, focus stimulation. We will have to see what are the effects of ketamine on the evoked potential monitoring.
MEPs are certainly accentuated, which may be
Hmm.
considered beneficial also on one side. But yes, what you are saying is also right.
With low doses.
Low doses
Sorry.
will slightly augment the
No,
motor
no.
evoked
With low
potentials.
doses.
Yeah. So I think it comes to the same thing as what Poonam said just now. It's all personalized. You have to personalize it and tailor it to the particular case, which she has done. Very good management, Poonam.
Thank you, ma'am. Thank you.
Yeah.
Thank you, ma'am. So can we take some questions or
Avinash sir?
No, it's 9:15, Sheetal. We will close now.
Okay, I
so
just wanted to
taking
Just
ask Dr.
present.
Poonam, can I ask sir?
Yes, last question.
Yeah, did we consider isoprenaline tablet preoperatively?
No, it was not advised by the cardiologist. Again, maybe because he was asymptomatic, but we had kept isoprenaline and it was probably a choice in this
And
patient.
the patient had aortic stenosis, no? So
Yes.
giving a vasopressor again can put a load on the.
Risk to the heart, yes. So we had decided only if it is a life-threatening bradycardia along with hypotension, we would start him on infusion. We had kept even adrenaline ready, but fortunately the patient did not require any of these. And pacing pads were also applied just in case of emergency.
Yeah, that's a very good step, yes.
So thank you very much. So I would like to inform you all that voting process for ISA national election for various posts is going to be start from 26 to 30th June. So kindly cast your vote and also promote all the members of SAMS to for their right of voting. Thank you very much. So now it's my immense pleasure and honor to propose the vote of thanks. I would like to provide my sincere gratitude towards both Chairperson Dr. Kekar Madam and Dr. Madhuri Kundi Madam for their sharing their experience and valuable inputs. I would like to thank all the speakers, Dr. Radha Saudekar, Dr. Ashwin Sonkamre, Dr. Sweta Sargavkar, Dr. Jayashree Rane, Dr. Fardin Qureshi, and Dr. Poonam Kodki for very crisp and very well managed case and presentation. And thank you everyone for joining today. And you are always support the SAMS in attending all the webinars. Thank you very much. Long live ISA, long live SAMS. Sir, want to say
Thank you.
something?
Thank you. Thank you.
Thank you,
very
everyone.
much. And good night.
Yeah.
Yes.
Good night.
Good night.
Bye.
खूप छान झालंय
Good night.
Thank you,
सगळे
everyone.
presentation
Yes,
खूपच
thank
छान
you.
झालंय. It was
Thank you,
very nice.
everyone.
Thank you.
Long
Thank
live
you.
ISA, long live
Thank
Shweta
ISA.
ma'am,
you.
we can
No,
see
no.
your video now.
Thank you,
I know.
Yes.
I am also surprised how it happened.
Ashwin sir, I wanted to know about the electric shock that you gave.
Please stop recording, Shilpa.
हो मी करते.
Recording stop है ना? अच्छा नहीं.
No.
Yeah, we give usually during the rewarming process when we don't achieve the rhythm, expected rhythm. So it is given with the
With
internal
the
pad.
electrodes directly on the heart.
Yeah, the internal paddles. They are called like internal
Okay,
paddles.
internal
So
paddles.
by the joules are very less. We usually get 15 joules or 20 joules. The current is very low that way.
Mhm.
It is used commonly in cardiac cases.
And Ashwin, can I ask one
Yeah.
difficulty?
Yeah.
Whenever this revascularization of a previously revascularized heart is done, how do they do the anastomosis?
Yeah, they put a jump graft distal to the stenos area. So if the artery is used previously, they'll have to go with a vein. The second GSV from the right leg. Usually the first one is from the left leg.
But
So
when now the graft from the leg has already thrombosed, why the mammary was not taken?
Lima to LED was done initially, the first one.
That
So
also had got blocked.
the LED got stenosed, not the Lima. So
Because
Lima
Lima
had a
usually
patent
doesn't
flow.
get blocked.
Yeah. Lima had a flow, but it was obstructed because of the distal stenosis. So they had to do. They tried some this thing, plastic, but unfortunately that got stuck up there. So there was no option left.
Yeah.
And otherwise also they had other blocks also in the other vessels. So only one graft was patent from the previous surgery. The SVG to PDA. That was only
Because
patent.
I think peripherally also the vessels were really, really narrow and thrombosed.
Yeah. Luckily he was not diabetic. So
Okay.
that was a plus
In
point.
spite of that.
I wanted to ask Jayashree madam, in between 3 attempts of intubation, did you require extra propofol or muscle relaxant or Jayashree madam, are you there?
Yes, madam. Yes, madam. I required again scoline and propofol 10 to 20 milligram.
Okay.
Every time, I gave injection scoline 3 times. First scoline dose, I waited till he comes out. Then second scoline and third scoline. 3 times scoline was given. And Buji, I didn't try Buji and other things to avoid airway edema. And I really didn't wanted the patient to go home with sore throat and other complaints.
So did you get bradycardia after the second dose of scoline?
No, sir. No, sir. Injection glycopyrrolate was given initially. Later on, it was not required, and I didn't notice any bradycardia.
That was good.
Jayashree madam, now video laryngoscopy is a mandatory instrument for any.
Yes, madam. Yes, madam.
So you
Yes,
should
yes,
have it,
yes.
madam.
Yes,
And one
ma'am.
thing I would like to advise 70-degree laryngoscopy. It is easily available rather than indirect laryngoscopy. And again, there is USG preoperative. It can help in your difficult cases. And your patient is very VIP, second year medical student.
Yeah. Yes, yes.
So,
So you should be
doctor,
go for evaluation for and documentation. If again
Yes.
need for further surgery, so you should advise.
Yeah. Yeah, I already told the relatives and the patient also about his difficult intubation, and I documented everything on his discharge card also.
Yes,
And
that is very
we have advised him for the next investigations about his about his laryngoscopy.
Then please insist on all the other investigations like
Yeah.
ultrasound and you see,
Yes.
because
Yes.
he's a young chap, he might require surgery again in his life.
Yes,
And
madam.
yeah.
Even
Yeah, yeah.
simple
Then
again
on
fiber optic
the
bronchoscopy can be done to see what for ENT.
Yes, madam. With ENT, I think we have planned it. We are thinking to plan it once he comes for follow-up. That time we are going to advise him about ENT. The immediate post-operatively, we didn't advise him about all the things because the relatives were not medico and they might got in different shock. So we thought ki after 1 month when he comes for follow-up, then we will advise him about ENT, fiber optic scopy and all things.
So video laryngoscope, second generation supraglottic airway, it is mandatory, not desired.
Yes, madam. Yes. That's why I told you ki immediately in the next week I took demo and I'm in search of buying it personally. Video laryngoscope. Surely I'm planning to buy.
I think he should be just a case of a interior larynx without any difficulties, I guess. There are no pathology there. It's just that he has got anterior larynx.
Yeah, but
So probably if we take the distances and do the ultrasound parameter, maybe we'll be able to understand what we missed out on our pre-op. I'm sure
Yes.
there'll be distances which will reflect on to tell us that this could be probably anterior
Yes.
larynx.
Yes, madam.
Rather
Yes,
than
madam. I totally agree, and I confess myself that first time when he underwent laparoscopic appendicectomy, that time I really missed about his airway findings, and I was not expecting this for when he was posted for this surgery. Young, thin, with mouth opening, good mouth opening, athletic young male. I was not expecting this much of anterior larynx.
So in spite of
so the
assessment, there is
distances may
always
be
chances of unanticipated.
Yes, madam. Yes,
obviously
madam.
normal, grossly
Yes.
normal, but when you actually see, you
Yeah.
will definitely get some clues.
Yes, madam.
And Scoline, how many? You said you used 3 doses.
Yes.
Yes.
The total subsequently second and
Total
third
dose.
dose, how much did you use?
Total 100, madam, because I gave time to come him out. Totally out of initial Scoline dose.
Okay,
Total 100 means first dose
100 plus 100 plus 100. Yes, ma'am.
100 you have already.
Oh, so you gave total of 300?
Yes, ma'am.
No, it's too
That's
much.
little scary.
Didn't you have any post-colon pains?
Pains. Muscles pain.
Yes.
Muscles pain.
No, ma'am. He was very comfortable post-operative. Rather, on the second day, he got discharged after 24 hours.
People should not take home message
Yeah,
to
right,
give
right.
so
Not
much
take.
of Scoline.
Recording
That's
is off.
even scary. And it can cause severe bradycardia and catastrophe. So second and third dose should be subsequently less. And of course, after a full dose of
Even can
atropine,
go into phase 2 block also. Repeated
absolutely.
doses of Scoline.
Absolutely. And then in a difficult case, you can be in a problem.
Yes.
And especially when the
Yes.
patient is likely to have
Come out.
bradycardia.
Yes. Yes.
Yeah.
I was thinking about bradycardia. That's why I was continuously monitoring, and I said also pulse was continuously monitored, and I didn't encounter bradycardia. That's why we continued with the third
And if
attempt.
at all you have to repeat the second dose, it is always better to combine that dose with uh, Avigolytic.
Yes.
Always,
Yes.
always. A
Yes.
second
Yes.
dose always needs a full
Mm.
dose of atropine
Yes.
because you don't know which patient will have this.
Yes.
Go into bradycardia. Yeah. I agree, ma'am. I agree.
Yeah.
Can we
Thank you,
conclude?
Jayashree madam, for answering all our questions and queries. I know we are talking it retrospectively, and you
Yes.
actually
Yes.
did the case there.
Yes,
Yes. Yes, sir.
it is more difficult.
And
That's how we
just
learn, right?
yeah,
Yes.
and actually, when
Yes.
you gave regional anesthesia, was
Huh?
was fiberscope standby there or no? Like,
No, it was only
No,
LMA
it was
Supreme
not.
was there. No fiber optic.
so what would you recommend your students? Like, suppose a
That's why I
anticipated
told. That's why I told madam ki if I face such case again, definitely I would like to have video laryngoscope with us.
So I think the
Yes.
best solution could have been to postpone for that day, arrange
Yeah.
for things, and then take the patient up second or third day because there
Because
was no
Only because
usually
emergency.
elective
yes,
surgery.
madam. Yes, madam. Yes, madam. You are very correct. Whenever we face a difficult intubation, we always postpone the case. But this time I didn't did it because I was very sure about my regional technique. This is the thing which I did differently. That's why I thought to
No,
present this
that is
case here.
okay. You can do the case under regional. That is not an issue. But if you are
Yes.
doing a case under regional and if
Yes.
something happens and you have to intubate, you can intubate. But here you know that the intubation is very, very difficult. So in such a
But
scenario, good that you went, you had a successful outcome. But a
yes,
take-home message will be always
postpone
err
the
on a
case.
safer side. Err on a safer
Postpone the
side.
case. Yes. Yes. Yes, madam.
Awaken the patient and
Awaken
postpone
the
the case.
patient and keep the because fiber optic it is not so difficult to arrange or video
Yes, ma'am.
laryngoscope not so difficult to arrange. So
Because
you
you were
could have
doing
taken
mass
2-3
ultrasound.
days and then post
Yes.
and especially when the patient was a medico. So
Yes,
the
ma'am.
We
patient
rely
becomes a
so
Madam,
medico.
much.
मला वाटतं everyone is trying to tell की suppose हा spinal झाला असता.
Yeah,
बरोबर
exactly.
आहे.
हा.
There
अगदी
can
बरोबर
be
आहे,
an
madam.
anaphylactic reactions,
नाही
anything can happen.
नाही मी काय विचार केला मॅम की हे मला का कळलं बिकॉज पेशंट आस्क मी अबाउट GA बट वेन the things when the things are getting correct, so no problem, but when the thing gets definitely in different way, then there is definitely a problem. When this patient was posted for laparoscopic appendicectomy, that time we were very confident and we did the case confidently, but this
Because
time
that time
as
you did
we
not know that you won't be able to intubate. That's what
yes
I'm trying to
yes
say.
yes sure
Huh.
sure yes ma'am
So
yes
in
ma'am
this
So what?
case, the wiser
and
step would have been to
yeah
postpone and
yeah
to
yeah
make things available and then redo the case. Okay.
So
okay
we
ma'am,
are
yes
always
madam,
so confident about our technical skills that we
yeah
are not prepared for the failure.
yes madam,
So
sure.
we know that spinal will work and I'll do it fine. We have it
Yeah.
99.99% yes. But 0.01% chance in case of difficulty, how are you prepared? That's what you will be asked even in the court of law. That
Yeah.
Yes ma'am,
if you knew this, why did you
yes
go
ma'am,
ahead? That is what is.
yes
How are you prepared for the failure? That's
yes
what we
madam,
have. These non-technical skills are important, the decision making for these things. So
yes
And
we
it's
have to
9:30.
be
Can we
very good in
conclude?
technical and sure about it. But yes, we have to understand, we have to be prepared for the failure. If we
yes
knowingly, if we are not prepared for the failure, that is a lapse.
Yes.
yes
True.
yes
Absolutely
ma'am.
true. Yes.
So thank you very much. Now we are
Thank you. Thank you.
Thank you so much.
Thank you, Kelkar madam,
Avinash.
Madhuri
Thank you,
madam.
everyone.
Shweta madam, I might connect to you to know more details about your
ये
technique.
माधुरी मैडम का चेहरा
I had
फोटो
some
नहीं दिखता
confusion.
Definitely, anytime. Shilpa, no problem. Yes.
तर आम्ही
And
बंद करू
Shweta,
का?
you please let me know about that, what I asked you, please.
Definitely, madam. Definitely, I will.
Yeah.
I will.
Thank
चला
you.
थँक यू
Thank you.
Thank you.
Madhuri madam गेल्या का?
हे
केळकर
हा,
madam?
good.
आहे का?
नाही आहेत
Yeah.
मॅडम आहेत.
माधुरी मॅडम
Thank you, everyone. Excellent presentation. It's very good. And discussion is also good.
Thank you,
Thank you.
sir. You always
you, sir.
attend our
Yeah.
webinar. Shobha
Thank
madam
you,
and you
Dr.
always
Ashwin, for
there for
challenging the case. Challenging case, Dr. Ashwin.
Thank you, sir.
Yes.
Yeah, very nice. You have done very good job.
Thank you very much, sir.
The redo cases are always challenging.
Yeah, very much, very much.
Yeah, yeah, yeah.
And
And
Sheetal's prediction of all cases was fantastic. Whosoever has done it.
defibrillation,
Sheetal, Shilpa,
defibrillation
whosoever
of
done it.
the in the open heart surgery is very common. Several times you have to use.
Mm-hmm. Yes, sir.
Yeah, with only just 20 joules like that.
Yeah, yeah,
Yeah.
Oh.
You are done next. Which hospital is it?
It is Sir JJ Hospital, Grant Government
JJ,
Medical
very
College.
good.
Yeah, Mumbai.
Excellent.
Mhm. Yeah. Thank
Excellent
you, sir.
work done. Yeah.
Yeah. Thank you,
चलो
sir.
end करायची ना
Good
meeting?
night.
Yeah.
Yeah,
Okay.
good night. Good
Good
night,
night.
I
Bye.
was
Good night,
wondering
everyone.
if my case would
And
be
long live
interesting at
ISA.
all
Long
for
live
this
ISA.
forum.
Yeah.
Nice.
I was
Sure.
wondering if the pain case is going to be interesting for this forum, but you
It
all
was
made
very
it very
much.
interesting.
No,
Yes,
it's
All
a
yes,
new
yes.
thing.
anesthesiologists are pain physicians, no?
Yes, yes, definitely.
In fact,
Yeah,
कान
yeah.
टवकारून एकदम मी ऐकत होते. हा, अच्छा असं असं this something new ना, so we
Thank you
wanted
for
to
that.
imbibe more.
पण ते केवढ्या निडल लावल्या होत्या बापरे खूप साऱ्या
Yeah, I
होत्या.
wanted to know, madam, bleeding नाही
तेवढे
होत का?
किती
But did you
No,
did
they are
you see
very
that
fine,
patient was so
Shilpa.
comfortable?
Very
Did you
fine.
see that the patient was comfortable
हो
and
खूपच
pain
comfortable.
free?
हो हो
हो.
पण bleeding नाही होत का
नाही,
मॅडम?
नाही, नाही.
नाही
They are very
नाही
small.
नाही.
No, very small needles, like
मॅडम किती
acupuncture
लावल्या
needle.
50 लावल्या का?
हा म्हणजे
50
30
needle पण.
पर्यंत तर होते 30 पर्यंत तर होते but depending on the muscle group there we want to kind of intend to stimulate no
Yeah,
so
yeah.
we have to put that much it's the
It is that
entire
current
arm
of
no
injury. It is that current of injury which stimulates the muscle, na?
yes yes
Yeah, yeah. That
so
Chang,
there
Dr.
are
Chang
electrical
philosophy.
stimulation also
Yes,
but we do
yes,
only
yes,
the
yes.
intramuscular putting the
Hmm,
physical needle so that the distal end of the nerve and the muscle remain have some stimulus we tell them to do massage we tell them to do the other passive ROM so that the muscle motor end plates should remain active till the proximal nerve tries to reach the distal the motor end plate so it requires a lot of extensive rehabilitation but patients are also cooperative and they do not have any other option what do they do
Yeah.
so we explain them the experimental nature and we go ahead and do it. But we are seeing some good results. So we are happy about it. Something we can offer them.
Yes,
It is a really very bad disability from there. If
Brachial
even if
plexus,
there is
young
10%,
patients.
20% recovery, it is great for the
Yes.
patient. Patients
Yes.
do daily
At least they
routine.
can be on their own. For
Yeah.
food and for routine thing, they are not dependent on caretakers or family members. So at
Yeah.
least that much also. If the other second patient went back to job. He's
Wow.
working as a security guard. So with he used to tell that if I'm moving, he used to lose the balance. So now with that little muscle at deltoid and
Recovery.
bicep that he started getting, he could move properly and he could go back to the job. So that video is also there, but because of short time, too
Yeah,
many
yeah.
things could not be shared. But basically, we see good results with this. At least in these two patients we have seen, and we have
Yeah.
seen it in peripheral nerve injury also, because the finer movements definitely help patient. You know, these are young patients. Really,
And you
it is.
can get the NCVs done with some donations or something.
We are trying, madam. Everything we try
Yeah.
and put through donation, but it is
Yeah.
painful also for the patients. So we thought we will wait for at least 3 months properly and then do it because so many needles and NCV EMG results also. If the needles are not put correctly, the interpretation is very different and it does not guide you. So we said, let us do clinical recovery. Let us do the clinical assessment, and then we will definitely get once EMG NCV done. But this is little too early to see. But this the assessment was done by the occupational therapist, and they do every muscle anti-gravity, gravity movement, and the power. So they do it very well, basically.
Yeah.
So we could get a good assessment from them. So that is a great help, basically.
Yeah. Thank you for introducing us to all this.
Yes,
शिल्पा तुला एंड करता येईल
As
मीटिंग.
pain
तू बस
physician,
छान.
I'm happy.
Mhm.
Ha, madam?
Yes, yes, very nice it is.
खूपच
Yeah,
छान. मी
yeah.
बघितलं मॅडमचं पेन क्लिनिक KEM ला गेली.
Oh, that
मी
is
पण
nice
2
of you.
वर्षापूर्वी पाहिलं.
Come again, all of you are invited.
Yes.
हो.
Please do come.
काय
Yes.
म्हणतात मॅडम, कशा आहेत केतकर मॅडम? ठीक.
हो, छान
तशाच
आहे. तुम्ही
दिसतात.
कसे आहात सगळे?
तुम्ही ठीक.
Madam is evergreen.
हो एपर.
आता भेटू ना आपण सॅम्सकॉनला.
हो
हो,
माझी
हो.
मुलगी हो माझी मुलगी पुण्याला आली आहे. नॅशनल इन्स्टिट्यूट ऑफ व्हायरॉलॉजी NIV पुणे.
अरे वा, बर.
ए-
मग तिला
एक वर्ष
भेटायला येत असतील तर ये घरी.
आता ती येणार आहे 26 ला. म्हणजे 1 वर्ष तिला ICMR च्या अगेन्स्ट प्रोजेक्ट आहे.
Okay, okay, okay. What has she done basically?
ती इंटिग्रेटेड MS बायोटेक्नॉलॉजी फ्रॉम BIT.
बर बर, गुड गुड, व्हेरी गुड.
चला
Good.
भेटू मॅम.
हो, बाय.
Okay, we
Thank
take
you.
leave. Thank
Thank
you,
you for
everyone. Thank
remembering
you,
me.
madam.
Thank you.
Yeah.
शिल्पा
Bye.
मीटिंग